Good morning, everyone. Thanks for getting up with us this morning and being a part of our training for today. Today we're going to be going over the care of the emergent neonate. This is certainly an issue I think that all of you have had to deal with at your facilities, and we're very pleased to know that there's several of you that have joined us today, and that many of you are kind of gathered in the room, which is totally great. We greatly appreciate that. If you would, please, we'd like for you to let us know how many of your folks are joining us in each of your rooms. And then also, we would also like to have every person that is in the training use some sort of device. Hopefully you have a smartphone or something that you could do our pre-test, and at the end of the training, the post-test and the evaluation. That's very important for us as we complete reporting on this to the Indiana State Department of Health. So we want to make sure that that gets done. So this training, as I've mentioned in our previous virtual training last week on stroke, that this is part of a 4-year project through the Indiana State Department of Health and the Indiana Hospital Association, a grant program called the Indiana Small Rural Hospital Improvement Grant. In this cohort, as you're aware, because we've been to each of your hospitals, is using simulation to promote patient safety. And we've very much enjoyed our partnership with both ISDH through the Office of Rural Health and the the Indiana Hospital Association. And we're looking forward to the next few years working with different hospitals than yourselves in doing training through simulation. Obviously, we'd like to be doing this in person, and as you know, our big thing is making sure that we're doing hands-on training using simulation, because we know how important it is for psychomotor skill development and for continued knowledge and learning. So unfortunately, COVID has changed a lot of that, and so we're dealing with that in the best way that we can. And the way that we've chosen to do this is through these virtual trainings. And so we're going to have some of our experts on here going through specific components of neonatal care. And we hope that it is at least a decent way for you to learn. And then if you have continued issues, then we can certainly address those moving forward. But for your needs as far as contact, these are the primary folks that you're going to contact through the RIC for any issues that you're having. Myself and Laura Livingston kind of co-lead our efforts on this kind of training. Our faculty for today's training are very experienced clinical staff that we've worked with for many years doing this particular kind of training, and you can see all of them here. And they've all had extensive experience in neonatal issues. They're all parts of the NICU transport team here at Union Hospital, and they know what they're doing. So I hope you learn as much as you can from them. So this is a significant issue and one that we've tried to tackle as best we can through the RIC. We know that 18 of 92 counties in Indiana have no hospital at all. 32 of those 92 counties also do not have obstetrical level services. And so if a baby is born in a lot of those hospitals and some of your hospitals, they're probably going to be born in the emergency department and then transferred to a hospital with OB services. We also know that the majority of infants born are born outside of a hospital with a NICU. And so if there are any kind of issues for the baby, then they are going to have to get transferred to a larger tertiary care facility. 11.6% of infants in Indiana are born premature. And then we know also that the infant mortality rate in Indiana is 7th worst in the United States at 7.1 per 1,000 live births. We also know that in 11 counties, that number's about 1 death per thousand is higher, and then 9.1 in 8 additional counties. So this is a big problem in our state, and one that we've tried to tackle in several different ways. And one particular
what's up today, guys? I'm doing some training.
We know that there is an increased risk for emergent neonatal issues in rural populations. The studies show that, and we also know that a lot of issues are part of the reason that is such the case, including things like insufficient thermal support, delayed use of surfactant, delayed initiation of assisted ventilation, and delayed transport to a facility with the NICU. So the RIC has been a part of this fight to decrease infant mortality, and our primary focus is again on training, as you know. We did a needs assessment of several critical access hospitals around the state of Indiana, and that needs assessment showed that there was significant need for training in neonatal and obstetrical emergencies, including the issues that you see here. And so our response to that was to create what we call the Neonatal Outreach Program. And our group has worked on this since 2014 or 2013 is when we did the original needs assessment. And our focus was to do training that was specific on what you would see in a rural hospital, and particularly for those, that work in emergency departments, because we know that that's a lot of times the place that these babies are going to be born. And so our focus was on doing training on airway management, ventilation type of issues, using the kind of equipment that you would use in your areas, and the training would be simulation based in nature. We'd put people into situations that we thought that would happen in their facilities, using the kind of equipment that you would use, but all using our high fidelity simulators that can do a lot of the things that an infant does through that training. And then as a component of that training, we would then go to your hospitals and actually do live simulations to basically do an evaluation of the training that we did. This is an example of a training we did at Putnam County Hospital, in which we showed up at 5 a.m. After calling on our ambulance, IHA, saying we're en route to your facility with an imminent birth of a 35-week gestation baby, and so on. And so we watched them and tested them out on how they would respond to the training, how they respond to the birth of this simulated baby. And then we would also look at their techniques on various components of resuscitation and stabilization, as well as look at their equipment, make sure that everything is, up to appropriate standards, and that there are no problems with expired supplies and that sort of thing. So one thing I would encourage all of you to do is, after you have training today, to go back and look at your processes, and maybe even do some run-throughs, some simulated type of births, even if it's a tabletop exercise, to make sure that you are doing everything that you're supposed to be doing during resuscitation. And then our team would come in and you would go through a transport, NICU transport report with the team to make sure that you're telling the team everything that needs to be told through that exchange. So I just wanted to give you some background on our history of utilizing the Neonatal Outreach Program, and then how we're going to kind of use that knowledge to do the virtual training for today. So we're going to start with a pre-course test, and I'm going to show that up on the screen here in a second. And then we're going to go through various components of management of the neonate, including airways, resuscitation, and stabilization techniques. We're going to go through a couple of simulation demonstrations with our team, and then the team is going to be on the line answering your questions related to all of these areas. And then at the end, we're going to do a pre-course test followed by a post-course evaluation. Again, it's very important for us, if each of the individuals within your rooms or what have you, complete the testing and evaluations, because it's one of the components that we use to improve the program, as well as stuff that we need for the Indiana State Department of Health. So with that, I've put up on the screen here our pre-test. There's a couple of ways that you can do this. You can just use the link that you see right here and go to that SurveyMonkey pre-test, or you can use your phone and put it up to the screen for the QR code and use your photo and then take the test that way. So what I'm going to do now is I'm going to give you about 5 to 7 minutes to do this test, and then after that we'll get back on the line and continue with the training. So if you could please go ahead and take the test now, and we will continue here in about 5 to 7 minutes. Okay, folks, I think we'll go ahead and get resumed here. If you still need some more time to complete the pretest, go ahead and continue doing that. We'll just watch the video, as the first video, as we're going here. And so the first component of the training we're going to go through is airway management, and that's going to be Jimmy McKenna. Jimmy is the manager of the respiratory therapy department at Union Hospital. He's been a respiratory therapist, I think, since 2007, and significant experience in neonatal training. If you get a chance to, you should go and watch some of his YouTube videos that he's done on a variety of different kinds of respiratory issues, not only with neonates, but also adults as well. And so those are at Jimmy McKenna on YouTube. If you just type that in, you'll find it. So with that, we're going to show the first component here. Let me get everything moved over to the right screen. And here we go.
For the neonatal outreach program through our local simulation center. Now, with the outreach program, we do training for rural hospitals in their emergency departments, specifically for those high acuity, low volume situations where a mom comes in and she delivers, and there's possibly problems with the delivery and problems with the neonate, so they have to do resuscitation. So there's multiple aspects to this, but this section is going to be about taking care of the airway. Positive pressure ventilation is super important. So, what'd you say? Oh, is it time? Cut to the intro. So I'm back here in the neonatal resuscitation room, and I want to give you a quick rundown of what the table looks like over here, of the equipment that we have available for an at-risk delivery. So let's get over there and take a look. So this is the table we set up for our neonatal resuscitative simulation, and I'll just go real quickly over this and then talk specifically more about some of the respiratory items. So epinephrine over here, 1 to 10,000 solution. We have some stopcocks and some 5 ml syringes, some syringes with saline. We also have a 500 bag of normal saline. We're going this way. We have 2 different sizes of ambu masks that will adapt to our T-piece resuscitator. We have 3 sizes of endotracheal tubes. So endotracheal tubes, the sizes we have are 2.5. And you can see that there, if I can get it to focus. So 2.5 ET2. Next size up, we have a 3.0, refers to the inner diameter of it. And the last one is a 3.5. Inside this 3.5, I had a stylet. So you can see a marked difference in the length of these endotracheal tubes. With the 2.0, 2.5, the 2.5, the 3.0 and the 3.5 here. Optimally, we'd like to have at least a 3 or a 3.5 in a neonate, and term neonate 3.5 would be the best if we get that in there. Now, you'll notice that these endotracheal tubes are a little different than the adult versions because for one, there's no cuff on them. So they're cuffless endotracheal tubes. These are made to actually seal inside the airway. So they will go actually in and they'll seal into place. You will have a minor amount of leak, and that's absolutely okay. But they will seal in, and there's no cuff that will seal it off. So another thing that you'll really run into, it's very easy for your endotracheal tube to migrate on your patients. So we'll really secure those airways. I'll show you some tricks for that too. And then you also have the lines on here, and these are really vocal cord lines. That's how we use them. So you just put these past the vocal cords, just barely past the vocal cords, and you know you're in the right spot. Generically, on a chest X-ray, we're looking below the clavicles and above the carina. But you know, on even a term neonate, it's only a space about that big, so you're not dealing with that much space. I have a stylet too. Of course, it's a semi-rigid stylet, so it can be moved and manipulated. It's usually an intubation person, a therapist, physician, or whoever's intubating. It's their preference if they want to use a stylet. It does give a little more rigidity to the endotracheal tube, especially if it's been under the warmer, and I'll show you that in a second too. But if it's under the warmer, it gets really floppy, and you try to stick it in between some cords, and it just wants to just kind of not go in because it's so floppy. So that's something to look at with the stylet. On the next part here, just a standard, this is a LED handle. Of course, it has a light inside the handle. You can check it that way to make sure the batteries are appropriate just by pressing down. You could also put the blade on and turn it on. You can see it's working there. So we usually just do it and test it before you go to the resuscitation or before the resuscitation starts, just to make sure this works. The nice thing is about these handles, you don't have to open up the blade. You can just hit this button and you can see that it turns on, and when it turns on, you know the light works. So, see the light working there. So for the blades, these are all Miller blades, which Miller blade is a straight blade. We have a Miller 1, a Miller 0. So of course 0 is smaller than a 1. And then we have a 00. Now this 00 actually isn't made for this handle, but we have it here just to show the three sizes of blades. So you can see the size difference in these. So we have the blades, you can see the size difference. Of course, that's the 1, the 0, and then the 00 right here. Double zeros are fine to use, but usually you can do almost everything that you can do with the 00 with a 0, because it's all going to be based upon how far you insert this in. So you just don't bury it all the way in there. You're going to have to insert it a smaller amount and make it work more like a 00. So a 0 is usually what you're looking for, a 0 or a 1. Like I said, with a 1, a 1's pretty big for a neonate, so it's going to go down there pretty far, but you're just going to use the front even third of it. So you're not going to use the whole blade. Bulb suction. We also have these as part of our neonatal resuscitative kit. This is a neonatal LMA. So it's called an air cue. This would be used in a situation that we couldn't get endotracheal tube in, and we could insert one of these, and it would essentially go down as a little, it's almost like the same version of this, so like a little ambu bag mask, but it's going to fit right over top of the glottis. So this slides in. This would work for ventilation. Not perfect, couldn't go on a vent with it, but it could work for resuscitation. We have a lot of these, and you'd only use it in a situation like maybe like a Pierre Bean or something like that, with something with a baby that has some kind of small jaw or recessed lower jaw that might be really difficult to intubate. In my career, I've seen a lot of kids intubated quite a few myself, neonates, and not had to use one of these yet, so thank goodness been able to get it with an endotracheal tube. But there definitely are some cases, and so you should feel somewhat proficient with this, because you don't want the first time you use it to be in a pinch where you've tried to intubate them for 10 minutes and you couldn't get it. So definitely practice with these things. This is a mucus suctioning device, so meconium aspirator. What am I thinking? Meconium aspirator. So very special piece of plastic that is invaluable, because actually this goes on top of the endotracheal tube. Suction goes right here. This is used like a little carburetor to direct the suction down the endotracheal tube, so suction's turned on. You would intubate with this, get to where you need to go, cover this hole and withdraw, and it's going to draw suction through the whole time. It's a good way to pull meconium out. Mucus. Maybe it could be meconium and mucus together, but it's a meconium aspirator. So it's something really good to have, and it's something that's really, really easy to lose. So I like to kind of stand it up if I can, because if you lay it down, it's clear, and sometimes you're fumbling around looking for it. Hopefully you don't have to do that in a pinch. So we also over here have end-tidal CO2. So obviously, since babies are humans, they exhale CO2 just like adults. And the really funny thing, it's in the same concentration because we're measuring centimeters of water pressure. So you're measuring the pressure of that coming out. So they will trigger these. Just because it's a low volume doesn't mean it won't trigger it. So because we're measuring pressure. So these are really good. I haven't opened this one up yet, but it's really good for verifying your endotracheal tubes, and especially if you have a good spontaneously breathing kid that's just needs his airway protected. It's nice to know that this endotracheal tube's in. It's very easy to miss an intubation on a neonate. And then, of course, we have our pulse oximeter. Always goes right upper extremity. We always do preductal sats, so right upper extremity every time. This is a nice little wrap, and that's also part of our kit. And then up here we have a regular DLE suction, not used a whole lot. Usually it can be used sometimes to, after intubation, to pull some air out of the stomach. You can pull that up into here if they have any extra retaining amniotic fluid in their stomach, blah, blah, blah. Not super important, but you'll see this on almost every resuscitation kit. And then this is kind of just a quick, kind of a generic setup for our umbilical line setup. So in the case of a resuscitation, it's going to be an emergent umbilical line. So as I like to say, with an emergent umbilical line, it's essentially like putting in a Foley catheter. So that's about the technique that you use for it. So this is just a quick little setup for that. It's not a sterile procedure by any stretch of the imagination. So it's a clean procedure, hopefully, but it's something you need it in a pinch, and then it can be resecured or changed, however that might be when you get back to the NICU after the resuscitation. So let's move on over to the resuscitator so we can get a good look at how to intubate. Just going to show you generically, and then a little bit of talk about ventilation. So I'm back here at the resuscitator. I have my Neo-T hooked up to the flow meter back there. Obviously, we would love to have a blender, but in this case, we're just going to use it off the wall because we are in a situation where we do not have a blender. So you're going to see our Neo-T. We want to set it up with some pressures right off the bat. So the first pressures that you're going to want, just generically, we're going to go between 20 and 25 for an inspiratory pressure and 5 for a PEEP. So let's set it. We include both sides. Right here, you're going to see a pressure show up. There we go. We're a little bit above 20, so not really where we want to be. We're going to take this dude right here. We're going to adjust it down a little bit. This is our controller to get about 20-ish, so I'm liking that. Check the PEEP. We're going to keep this end occluded. We're going to look at the PEEP level, and we're a little bit over 5 there, so let's back it off just a little bit. You can see it changing, so I'm liking that. About 20 over 5. So now we know that's set up. So there's one aspect of it. The second thing we want to get ready before the baby's born is we want to make sure we get our pulse oximeter ready. So we have our pulse oximeter here, our oximeter cable. We're going to hook it up so there's no fumbling with that during the delivery, and then also we're bringing the child over. We want to have this close by so we're not looking at open packages and whatnot. So we have our positive pressure. We have our pulse oximeter. We're going to grab a standard mask. This is an infant mask. I'm going to put it on the end here. Have this ready also. I like to check my pressures without the mask on. You'll see sometimes that we'll put it on here or something like this. I don't think that gives a good seal. So I like to really have this, check the pressures this way, then put the mask on. Now it's ready to go. So I'm not dependent upon, having a pressure that's off by sealing it, trying to seal it on the bed. So other things I might need, of course, we'll need a towel, some sterile towels if we have sterile towels, but just because we're going to warm, dry, and stimulate initially when this child's born, and look for respiration. So check respirations, check for a heart rate. So everything we have is really built around 30 seconds of positive pressure ventilation. And so we're going to need to know when those 30 seconds are up. So that's really important up here on this part. So let me zoom up here a little bit, go up. You can see this is going to be our timer. So I can turn this timer on if it was plugged in. Oh, got to turn power on. Let's get it going here. And this is another thing you'll want to do. You'll want to turn the power on first, because you have this nice light here. We'll turn that on. That's a keypad lock. Not really worried about that as much. But once this is ready, and it's on pre-warm, so it's warming from up here. If you go down to down to baby, it's actually going to work off the servo unit, which is this right here. So it's going to work off baby's skin temperature, and it's going to adjust this temp by what the baby's skin temp is. So that's what servo is, or manual. Right now we're just doing pre-warm, trying to warm the area. Cold babies do not breathe. It's one of the most important things I've ever been taught. So they need to be warm, dried, and stimulated, and then continuous warmth coming in, because they just don't like to breathe when they get cold. So first of all, what I'm going to do from the respiratory therapy side, or even the assist, if I'm going to be like a second nurse, or the person not actually catching the baby or delivering the baby to the resuscitator, I'm going to have this stuff ready. I'm going to check my FiO2. If I have a blender, I'm going to start on room air. Turn my blender to room air. I'm going to check my positive pressure rating, maybe have a handle and a blade close by with an endotracheal tube close by, my pulse ox ready, and turn this on. We're also going to turn our oxygen on, if you have oxygen on your resuscitator, and then suction too, to have that ready. Those are your biggies that you need before the child's born. So we come in, get ready, and then after that, I'm just usually waiting. I usually put my hand up here, and I wait till the child comes out and the baby's born, and I will hit the start button, because that is so important to have that timer right here going off, because that's everything we do is built around those 30 seconds of positive pressure ventilation. So we really need to have a good timer and to be in time with our partners that we're working with. So it's really important to get that. After I feel like I have that, I feel like I can wait here and I'm ready for the child to be born. If it's an emergent delivery and I don't get a chance to set this up, that's when it gets a little bit more funky, because you may be fumbling for some stuff, and you may be setting up pressures on this really, really quick if you have a spontaneous birth. So it's nice to have a little bit of warning and get the stuff set up early. It just makes sure everything's there and you're not fumbling over stuff. So let me show you a little bit about sealing this mask on, and then show a little bit with intubation. Another nice aspect that you would have is a little bit of a towel roll. Now, we don't want it too much, and that might be a little bit too much for this guy, but to have a towel roll to be able to get this kid in more of a sniffing position, so a more of a level position here, instead of having his head down like this or back like this, right, that level position, that's where his airway is going to be most open for positive pressure ventilation. So initially comes over, warm, dry, stimulate. Of course, we're going to suction at the perineum, but they're going to warm, dry, stimulate, check for a heart rate, looking for respirations. Simulator's not turned on right now, so he has no heart rate. So what we're going to do in that case is we're going to start positive pressure ventilation. So I need to do a couple different things real quick. I need to get a good seal, and I need to note the time on the resuscitator. So because I want to look at 30 seconds from this time to reassess. So we're going to seal this on. Of course, that's where the nose goes, right there. I'm going to seal it on. And you're going to notice a little bit when I seal it on, should get a little bit of pressure. And you see, uh-oh, what's the deal? I'm trying to ventilate and it's not going up to 20. So if it's not working that way and you're not seeing chest rise, which you won't because it's not going to 20, you do a couple different things here. You're going to do what they call Mr. SOPA. So it is an acronym for MRSOPA. So M is the mask fitting. Do I need to readjust it? So mask and readjust, MR. So we're going to put the mask on, we're going to readjust it a little bit. Sometimes you get a little funkiness in one of these seals here, so you're going to readjust the mask. So that's the first thing. And then I try to ventilate, not get anything there. The next one is S, so that's suction. So now I can suction the kids. So I can go over I can do a little bit of suctioning, try to go back. Don't want to go too deep because you'll cause an vasovagal a little bit. So you want to go back, see if you can get anything out. Okay. Try to get a good seal. Try to give a breath. I'm still not getting the pressures I need. So the next one's is O. So open the airway. So you can see O for open the airway. This guy's airway is really nice and open, almost constantly. Hey. And so he's got a nice open airway. You kind of adjust the jaw a little bit. I always like to kind of, you can do a little, they got nice little jaws if you can get a hold of them here, but they're really cartilaginous, so their jaw moves quite a bit. So you can kind of move it down a little bit. You don't want to dislocate it, but just put a little bit of movement on it. Maybe the tongue is stuck in a weird position or something. So O for open the airway. Not getting anything there. The next one is P, and that's actually increasing pressure. So we got to go over here, occlude, and crank up the pressure a little bit. So if I get my occlusion here, and let's say I was at 20, and then I go up on my pressure, let's say I go up to about 30. Not super common to do. We can increase the pressure, and I'm still not getting the ventilation. The last thing is, after P is A, so that's artificial airway. So that's when we would go to use an artificial airway, and we're going to intubate the kid. So we'll do that in just a second. Now, if I was ventilating and I was getting good pressures, one thing I always like to do, and I always like to have my eyes totally in line with this kid's chest and my manometer, because I want to monitor both of those things at the same time. So if I can get a good shot here, and I might have to go down a little bit, but if I'm ventilating this kid, if I'm ventilating a kid, I like to have a direct line of sight going straight down through here across this manometer. It's really nice to have a manometer here, and then to the kid's chest. So when I'm ventilating, I want to see the corresponding chest rise with the manometer going to the pressure I have set. If I'm using a manometer that's on the backside of the resuscitator, I'm doing the same thing, the direct line of sight. And I think that's really important. And another thing that's really important is to focus in on your ventilations, because when you focus in on your ventilations, you're not going to get distracted about other things going on, because it's really easy to get distracted. They're throwing out heart rates and all kinds of different things, and mom's history, and mom might be screaming, and dad might be in the room and mad about something, or he's right up close to you taking pictures, which that's fine, but you have to be really focused on this, because every time you have to give 30 seconds of good positive pressure. If you don't do it, you could be doing chest compressions on a kid that didn't need it, because the adequacy of your PPV really dictates how you flow down the algorithm. So you have to have good PPV. If it takes 20 seconds to get everything lined up and the Mr. Sofa, and you get to O and open the airway and it starts filling, you start from there, now you do 30 seconds. And then after when those 30 seconds are up, then you'll want to reassess. But having that 30 seconds of good positive pressure is really important. You shouldn't be thinking about anything else, or drug doses, or this, or that, or umbilical lines, and that kind of thing. No, you focused in, block out the rest of the world. You're focused in on doing proper ventilations 40 to 60 times per minute and seeing adequate chest rise. And then you see the good response on your manometer. I'll tell you, it's something that's really hard to do, and you have to be very, very deliberate with it in the delivery room, because if not, you will. And I mean, I think there's a simulation that's videoed recently where I miss a breath, because I started thinking about some other dosage that was thrown out, and I was like, oh, I don't know if that's right. I was thinking about that kind of stuff, and I wasn't focusing on your job. Biggest thing is do your job. So your job in this case is ventilating this kid. So you want to make sure you get good positive pressure ventilation. That straight line of sight, I think, is really important, having a good seal on the mask, because you don't want to have to do CPR on a kid that doesn't need it. And it's a lot of times, over 95% of the time, you can pull a kid out with good positive pressure ventilation. That's why it's important, and that's why there's a whole section that we teach on it. So it's really important to get this down. If you learn nothing else, no positive pressure. If you do really junky positive pressure ventilation, you're going to end up doing chest compressions and maybe drugs on a kid that didn't need it. So that's my soapbox on positive pressure ventilation. It's just not this easy. It's not just this. Okay, so there's actually a lot to it. So I don't want to, it's definitely not just simply squeezing a bag or occluding that. It's a vital part of neonatal resuscitation. So let's go over now intubation. So I'm gonna put on. Actually, I might upgrade a little bit. I want to show you how to do it with a 1. So I have my handle, I have a 1 blade, which is way too long. And I'll get a close up here. This blade, obviously, if I put that thing in, shoot, that thing is gonna be like all the way down the carina itself. So I'm not gonna bury this thing all the way and shove it around the corner like that. Not good, don't do that. So with all intubations, you only use what you need of this blade. Just because it's this long doesn't mean I have to use it that way. So you only use the tip. And so when you do this, you're going to go in on the right hand side, you're going to sweep the tongue a little bit, and then you're going to lift, and you're going to lift this soft tissue up. Now let me get a little bit different view here. So when you go in, you're going to lift this up like this, and so it's going to think about lifting this soft tissue right here. Think about lifting it upward. You're going to want to go straight up with it. None of this stuff right here, cranking. I don't like cranking, especially if these cases they don't have to. This is not a lever. This is not used as a lever like this. This is used just to lift the soft tissue up. So if anything else, it should be all being lifted up this direction. So the kid won't lift up in most cases unless they're really light. But usually this area right here is really cartilaginous. It's really easy to kind of move and to be able to find that airway. So what I'm going to do, left hand, I'm going in. So I'm going to go in, not going to bury it, just going to use the tip, go behind the tongue. I'm going to go in and look. I see the epiglottis, which is the little piece of tissue that hangs over top of your trachea. If you see the epiglottis, you're in business, because right behind that dude, boom, that's going to be your glottis. So if you see the epiglottis and you're in there and you see, oh, that's the epiglottis, there's a weird piece of tissue sitting right there, and that's what it'll kind of look like. It won't have a fingernail on it, but it'll look like a piece of tissue. And you just go in and you just do a little flippy-do like that. It's going to be right behind it is going to be the glottis and where you want to put the endotracheal tube. So it's really important, because we don't do a lot of video intubations. It's really important that the endotracheal tube gets in the right spot. So let me show you a little bit of a view from behind me. So you can see that I'm going to use a 3.5 ET tube here with a stylet in this case. So this is always going to go over here on the right side, because when I go in to intubate, I'm going to get the tube over here on the right side to put it in every time. So if you're assisting, you always are on the right side of the patient getting ready to hand in the tracheal tube. When you hand it, don't hand it like this, because they may not be looking, and you always want to hand it this way so they can have it and go directly in with it. Because once you view these vocal cords, you won't want to take your eyes off of them, and I'll show you why. And so you can see I'm going to go back here, and if you look down in there now, you can see that dark hole. That actually is the esophagus, so that's posterior. So when I go back, I'm going to want to look anterior to that. So you'll see I'll lift, and you can just see right there, see the base of those vocal cords? You can see the dark hole a little higher, and the vocal cords. Now this is not exactly what every trachea looks like, but it's a pretty good representation of the amount of pressure you have to do. So if we pull back, you can see I'm putting some pressure, but then I'm also using my pinky. Now this is another little technique that we use, that I've seen used. You use your pinky right here as a little bit of cricoid pressure. So this is like next level type stuff. But if you use your pinky as a little cricoid pressure, I'll show you the difference. So if I'm going to go in and take a look, of course, right there, there is a little flap of skin. It's hard to see the epiglottis in this little dude. But if we go here on the other side of it, oh, there it is. So if I push down on it, you can see it there. You see on the other side. If I go around it, and now I lift up, and I look back in, I'm going to see my cords there. So you can see vocal cords. Now watch, if I put a little pressure on my pinky, it does bring it down a little bit more in view, and that's just a little bit of pressure. Just makes it stick out a little bit more, so that helps to use your pinky there a little bit. So let's go in and we're going to intubate this child. So you're going to see that I'm going to go in, I'm going to initially view, I see the epiglottis, I'm going to move it out of the way, I'm going to lift, I can see the cords, add a little more pressure, I'm going to keep my eye on the cords while my assistant hands me the endotracheal tube. At that time I'm going to insert it from the side, and I'm going to watch as that endotracheal tube goes through the vocal cords. So at that point it's through the vocal cords. I'll withdraw the blade, still securing the tube right here. I'm going to remove the stylet, and I'm going to secure the tube to the top of the mouth, and that's really the best thing to do. A lot of people will grab it here. It has a tendency to slide. Securing it to the top of the mouth until you can get it taped is really important, because this one finger securing it really helps a lot to keep it from moving up and down a lot. Now if you want to see that it's in the right spot, you can go in and view. A lot in the mouth down there. You can see that, you can see stomach down there, and then you can see if I go in and I lift, you can see there it is through the vocal cords. You can see the endotracheal tube in the right spot. So you wouldn't check it like that, but the next thing that you would do is you would have it secured, pop off the mask, adapt this, and now when I give it, it's going up to the high pressure I set, because remember I went through Mr. Sopa, added the extra pressure, and now it's sealing. So really we needed to get to the A on Mr. Sopa to get a good seal on this kid. So ideally I probably would go occlude those, back this down just a little bit. Really cool. So if I just adapt it to it, you see it goes straight to 5. Now we're ventilating. So secure that tube and ventilate your kid at 20/5. So now you have a good ET tube. One other aspect, of course, is exhaled CO2. So even if you saw it go through the cords, it's nice to put your exhaled CO2 on here. Pull this tab out. When I pull the tab out, it then allows it to this film in here to change if it's in the presence of CO2. So if I see this and I see, oh look, there's no change, that's not good. That means there's no exhaled CO2. It should be changing to yellow. What it should look like is this. Really the best way to demonstrate this is just to show you how it changes when it gets exhaled air coming back through it. So there it is on the end of the ET tube. Right now it is very blue, and you can see it turn to yellow in the presence of at least 5% carbon dioxide. So that's what you're going to see. You're looking for yellow in 5%. It will change a little greenish if it's 1 to 2. You really like it to be 5%. So there's blue. There's your change. That's another great indicator that it's in the trachea, because even after 2 breaths, you should not be turning yellow if you're in the stomach. Okay, very rarely will it turn yellow in the stomach, but after 2 breaths, it will not. The percentage is ultra low. So, way lower than what it would take to change this. So, having that, the visualizing it through the cords is really important. Another one is exhale CO2 is really important. And a third one is you get a good chest rise, and then also you should start to see your heart rate increase, because you did everything you needed, MRSOPA, and now you should start seeing visual chest rise for one, but then your heart rate should react to that. So if you had a low heart rate, it should start increasing. If not, you've got other issues that move you farther down the algorithm. But as far as airway goes, that's as far as it gets. If you can intubate a neonate in these cases, that's really, really good. You're at a really good point, because there's a lot of other stuff you can do, but having a secure airway with adequate chest rise and good ventilation is extremely, extremely important. So Another thing, another little thing that we kind of use, and I'll go back over here just to show you how this works, is another little trick that we might use when trying to initially insert that laryngoscope into their mouth. So before I insert my blade, which this blade's really kind of big for this kid, but I'm just going to use the front part of it. 0 is probably optimal. Before we do that, this oral pharynx back here, especially from this kid's been in amniotic fluid. Amniotic fluid, if you don't know, is extremely slippery. And when you do this, and I'm not exaggerating when you do this, when you put this back in here, it will go like this. There will be hard to keep control of it because it is so slippery. So one thing we commonly do is take a 2x2 gauze and we push it down. Of course, a gloved hand, just kind of do a quick wipe off of the tongue, and it gives you a little bit more grip when it goes to lifting up this airway, because you are working with fractions of a centimeter, and if you move much at all, you won't be able to see that trachea. So being able to have a piece of gauze, doing a quick wipe on the tongue, and then going for it is really important. So having 2x2 gauze is really nice. Another nice thing to add to your resuscitator or your kit right before you intubate, so you can get that stuff ready. I hope you guys learned something today from this demonstration on a neonate about taking care of the airway. And like I said before, positive pressure ventilation is so important. So practicing before you have to do it clinically is vital. So I really recommend, if you haven't used your Neo-T for a while, or you haven't used T-piece resuscitation, to get it out every month. Practice changing those pressures. Maybe put it on a test lung so you can see, you know, the rebound from the test lung when you have appropriate seal. And then also, if you have the opportunity to go to a simulation center, that's a really nice thing also. Of course, neonatal intubation should not be tried by anybody who is not properly trained in it. This is not like watch Jimmy's video and then go intubate a baby. It's nothing like that, because it takes a lot of time and work, and actually perfecting it in the adult world before you come over to the neonatal world. So it's something that shouldn't be taken very lightly, and it's an extremely important part of neonatal resuscitation. Big keys, of course, positive pressure ventilation, having that good seal, the Mr. SOPA, and then selecting that endotracheal tube appropriately, wiping off the back of the tongue, going in, visualizing, inserting it, verifying it with end-tidal CO2. Those are all different aspects that you can work on and practice before you have to use it in a real life scenario, because if you're the airway person, your job is vitally important in a neonatal resuscitation. So I really appreciate you watching. Make sure you like and subscribe to the RT Clinic. I've got a lot of other videos, and I've also linked the other videos from the Rural Health Innovation Collaborative in my playlist for this one. So in the playlist, you'll also see some other videos from this neonatal outreach program, and watch them, comment on them, share them with your friends, subscribe to the RHIC, the Rural Health Innovation Collaborative, and we'll see you in the next video. Later. What's up today, guys? I'm doing
Right. So I'm going to stop sharing my screen here, and Jimmy's going to get on here as well, so we can kind of have a little short question and answer period here. Jimmy, are you on there? We see you on there.
Hey, how's it going?
We can see you a little bit. Maybe you could scoot up just a little so we could see you better.
Put you in the front row.
So if you want to, all of you, you can add some questions into the chat room, but we certainly don't mind if you go ahead and just ask some questions right on the screen here. Just talk to us. That's fine too. Anybody have any questions about airway management of the neonate? While we're waiting, Jimmy, do you have anything you want to add?
Yeah, I think there was one specific area that I left out in there that would work really good for critical access hospitals, and that's differentiation between the self-inflating bag, the flow-inflating bag, and the T-piece resuscitator. And I actually have a video on that, and I just need to do some editing on it. That should have been part of this, but it's really important because not all places have a T-piece resuscitator, although that is absolutely like what is ideal. A lot of places would have a self-inflating bag. So there's a lot to talk about with that, especially people that haven't used it a lot. It has a manometer on it, pop-off valves, things like that. So that's something I'm going to post. I'm going to give to the Rick to post, just kind of to talk about those different aspects.
Any questions for Jimmy? We really, really enjoy awkward pauses on Zoom. It's a part of my life for the last 2 months. So I've learned to just kind of live with it and just let it go for a while. So it's fine. Okay, well, if there are no additional questions right now, you certainly can you continue to add those to the chat. We really want to answer your questions. So do that if you think of anything for airway management as we're going through the rest of the videos. Next on our list is going through some of the components of resuscitation, NRP with Carrie Stewart. So I'm going to share my screen again here in a second.
Good afternoon, everyone. I am Carrie Stewart, and I am a clinical simulation specialist here at the RIC and also an NRP instructor. So today I am going to be reviewing with you. It's going to be an NRP review for our neonatal outreach. So we'll just go through a few things, and then we'll also be practicing some skills. So the initial steps of your newborn care, these are our rapid fire questions that we're going to be asking that drives any of our resuscitation. So if you go to a delivery, if there is a delivery in labor room, if there's one in the ER, if you have a baby that comes in, we want to know, is that baby term? Does the baby have good tone? Is the baby crying and have good tone? Is the baby breathing? So if we answer yes to all of those questions, then we can place that baby skin to skin with mom, and we can do all of our routine care on mom's chest. If the answer is no to any of those questions, we need to take that baby to the warmer and initiate the steps of NRP. So our initial steps include those first steps, the reevaluation and the beginning of ventilation. So that's what we call the golden minute. So we're warming that baby off, we're placing the baby on warm linen on mom's chest, or we can place the baby on the radiant warmer if we anticipate that the baby will need to be resuscitated. We're going to stimulate the baby by drying that baby off with those pre-warmed linens. We're going to remove that wet linen. Thermal regulation is huge, so we need to make sure that that baby's not laying on wet, blankets or anything. We're going to clear the secretions from the mouth and the nose, just wipe their mouth and nose, and then we're going to assess the heart rate. So warm, dry, stimulate, heart rate. If our baby is gasping or if our heart rate is less than 100, we want to take that baby to the warmer, place them in the sniffing position with the nose up to the ceiling. And we can use a shoulder roll if, and that gets that baby in perfect position, the sniffing position that we want them to be. And then we would place a pulse ox on the right hand or the right wrist and put the baby on the EKG monitor. And then if we need to, we can go down the rest of the steps of the NRP algorithm, ventilate, oxygenate, initiate our chest compressions, and hopefully not, but administer epi or volume expanders. So just briefly, I want to touch on this, and these are just considerations to think about after your baby is born, after the baby is born. Stimulation during delivery. So positioning and drying the infant should be enough to get them to take that initial breath and to initiate breathing in a newborn. Brief tactile stimulation we can attempt. We can rub their back, we can rub their trunk, kind of rub their feet. We just don't want to have prolonged tactile stimulation or being over vigorous. You know, we definitely don't want to cause bruising or anything like that. If that little bit of stimulation does not get that baby to breathe, then we know that we're going to be anticipating our PPV. Suctioning after delivery, this is another thing I want you to consider. So suctioning is definitely warranted if the baby's not breathing, we're anticipating starting PPV. That baby may have secretions in the back of its throat, and we're not going to get effective PPV if there in fact are secretions in the back of the throat. We can clear those secretions, just turn the baby's head to the side, allow those secretions to just fall on the side of the cheek, and then you can use a bulb syringe to get those out. We want to use gentle suction with a bulb syringe. You'll suction the mouth and then the nose for visible secretions. What I want you to remember is we don't want to blindly just go to the back of the throat and fishing around for anything. It can damage that soft tissue back there. The other thing is that vigorous suctioning may vagal that baby down, and then we're causing the heart rate to go down, and we have to intervene. If you are having to suction, it may be a situation where the baby has swallowed a lot of amniotic fluid and the belly is distended. So we may need to clear that belly out so that those lung fields can come down and we have better aeration. So to remove those, we can use a DeLee, we can use a suction catheter, but we just want it starting at 80 to 100 is where we want our suction to be. So oxygen use after delivery. We can use free flow oxygen if our oximeter reading is below that target range for the baby's age. So you can see the grid I have here on the left, and in our facility we have these on all of the warmers. So then that way it gives caregivers a guide. So if we know that the baby's 1 minute old, we know our sats may be, in the 60s. So as long as our pulse ox is on the right wrist, hopefully we'll get a good reading. And if we're past our 10 minutes of age and we're still not above 85%, that baby may need some supplemental oxygen. What I want you to remember with that is that if we are giving free flow oxygen, the infant needs to be breathing. Anything where the baby's apneic or not effectively taking good effective breaths, then we may need to intervene with some PPV. So we'll go into greater detail in the airway portion, or you may have already gotten a lot of information in the airway portion, but just to review, for NRP, any newborn that's greater than 35 weeks, we can start out at room air. Less than 35 weeks, that's that target range that you can start out at room air, but you may need to start out a little higher. So some physicians may start out at 25%, some start out at 30%. It's just really kind of their preference, any baby that's slightly preterm. And remember, like we talked about in the last slide, babies are maybe cyanotic for several minutes, up to 10 minutes. I mean, after delivery. They're used to living in a very hypoxic environment. So they're used to living in a 60%, FiO2 of 60%. So after delivery, we give them that time to really come around and get above 85%. But if the baby is laboring, we can't maintain our oxygen saturations, we may need to provide CPAP using our T-piece just to get their oxygen saturations up. So we'll review as well the difference between CPAP and our PPV. CPAP on a T-piece resuscitator provides PEEP. So that's that pressure that's maintained in the lungs between breaths. We don't want those little alveoli to collapse. So it helps keep the lungs open. We usually set the PEEP at 5. And that can be achieved just by holding the mask tightly over the baby's face just to create a seal. We don't want it so tight that we're smashing it down on the baby's face, smashing their nose, or pushing their head into the bed. It just, a nice seal should give you the pressure that you need. And that's just, like I said, just to keep those little alveoli open. PPV, on the other hand, with a T-piece resuscitator, we need to be thinking about those manual breaths, giving that positive pressure ventilation if our baby's apneic or if our heart rate is less than 100. The caregiver actually gives the manual breaths. So we've got our mask, we've got a nice seal, and we occlude that hole and give that baby a manual breath because they're not, they don't have effective breathing on their own, or they may be apneic. Usually our PIP starts out anywhere from 20 to 25 centimeters. And our PEEP, the suggested initial setting still is 5 centimeters. So initiating our PPV, I know I've kind of gone into detail about this, but we're going to initiate our positive pressure ventilation after completing our initial steps if our baby remains apneic or if our heart rate is less than 100. We want that rate to be between 40 and 60 breaths a minute. If we use the cadence of breathe 2, 3, breathe 2, 3, breathe 2, 3, that will get us in the target range of our breaths per minute. It's preferred to use a T-piece resuscitator. It provides that steady PEEP that we need to keep those little alveoli open. Some facilities, our facility, we use a NEOT when we're transporting. And I also want you to remember too that you can use a self-inflating bag if there's an emergent delivery outside of labor room. You may have a baby that delivers in mother baby, or it might deliver in the ER, or it could possibly even deliver in the parking lot. So we can give those manual breaths. We're not giving any extra oxygen, but we can give some manual breaths. And also when we are giving effective breaths, that majority of the time is going to, kick that heart rate up. So the most important indicator of successful PPV is that rise in heart rate. So right now we're going to pause and we're going to do some skills practice. I want you to practice the cadence for our PPV. When we do this, you can use your self-inflating bag, or if you're practicing with a T-piece resuscitator, you'll actually occlude the hole to give that baby a breath. Okay, as we are practicing our skills, the first one I'm going to use is just our T-piece resuscitator. And we want to make sure that we have different size masks for different size infants. So I have the newborn mask. What I want you to remember here is we want the top to just go over the bridge of the nose, and then the bottom to just be right at the chin. So we'll place the mask on the chin, put it on the bridge of the nose, and then if we're giving those manual breaths, you can see here that I'm not smashing down on that soft neck tissue or anything like that. I'm just gently holding it over the face to create a seal. And if I want to provide a manual breath, remember our cadence. Breathe 2, 3, breathe 2, 3, breathe 2, 3, breathe 2, 3. And again, that will give you the rate that we need it to be at. If you're not using a T-piece, and let's say that we have a self-inflating bag, then same concept. We'll just put the bag or put the mask over the face, and we can squeeze the bag. We can give the baby manual breaths by squeezing the bag. Breathe 2, 3, breathe 2, 3, breathe 2, 3, breathe 2, 3. And it doesn't need to be anything, where you're squeezing the entire bag. It's just enough to inflate those lungs. Breathe 2, 3, breathe 2, 3. Okay, I briefly want to touch on Mr. Sopa. For the airway portion, it might have gone into greater detail, but just remember when we're doing giving positive pressure ventilation, we may need to do the corrective steps. So we've got our mask on. We've been breathe 2, 3, breathe 2, 3, breathe 2, 3. And we're not seeing good chest rise. M, we're going to reposition that mask. So we're going to make sure that that mask is on the bridge of the nose, just at the chin. And then we'll try to reposition the head. Are we too far down? Are we too far back? We're hyperextended. We want to make sure that we're in that sniffing position with our nose up to the ceiling. And then we'll go back at it. Breathe 2, 3, breathe 2, 3, breathe 2, 3. And if we're not seeing any difference there, we're going to try to suction out the mouth, see if there's anything including the airway, and then opening the mouth just a little bit, just to make sure that we can get that air in. And then we'll try it again. Breathe 2, 3, breathe 2, 3, breathe 2, 3. If we're still not seeing a rise in that heart rate by taking all of those corrective steps, then we know we're probably headed to that alternate airway. So we need to be thinking about maybe increasing our pressure a little bit. If we're at 5, we may need to increase it to 6, and then possibly thinking about an alternate airway. Okay, moving on to our alternate airway. We've done all those corrective steps. We've readjusted our mask. We have repositioned the head, gotten that baby in the sniffing position. We suctioned out the mouth to see if there's any extra secretions back there. We've increased our pressure, and nothing has worked. We're going to be thinking about an alternate airway. If we are assisting a physician, or if we are assisting respiratory therapy, they are always going to hold that laryngoscope in their left hand. So we want to make sure that our suction is ready, our ET tube, that we can hand all that to them in their right hand. Once they get visualization of those cords, we don't want them to take their eyes off those cords. So we want to make sure that once they have visualized the cords, we hand everything to them in their right hand. We try to have it completed within 30 seconds. Remember, I just want you to remember that the baby's not being ventilated during that time. If we can, use a CO2 detector. If it's available, we want equal breath sounds, symmetrical chest rise. You may hear breath sounds louder on the right if the tube is inserted too far. And you say it, you can let respiratory or the physician know you're louder on the right. They may pull it back a tad, and then they'll give a few more breaths, and you should equal out. Just remember, in NRP, ventilation is the single most important step. We can use LMAs. We try to make just 2 to 3 attempts, so we're not causing any damage to that soft tissue, and also just utilizing our RTs. So initiating our chest compressions. Chest compressions are indicated if our heart rate is less than 60, despite our 30 seconds of adequate ventilation that inflates the lungs. So that's not 30 seconds of trying to get our mask to fit. It is actual 30 seconds of we're seeing good chest rise, good movement. The 2-thumb technique is preferred. We want the thumbs placed just below the nipple line, side by side, or you can put one on top of the other. We're encircling the baby's chest. We're providing support for that back, and the compressor counts. So another cadence I want you to remember is 1 and 2 and 3 and breathe. And when we get to breathe, we're going to pause so that respiratory or the physician can initiate that breath for them. We want a good full recoil. Try not to take those thumbs off of the chest, keep them in contact with the chest, and switch out. Even on little ones, even on babies, it gets so tiring. You have the adrenaline running. It may not be a delivery that you anticipated, and you certainly didn't anticipate having to do CPR. So it does get tiring. A good time to switch is at that 1 minute mark when you are checking the heart rate. So we have initiated our chest compressions. We want to turn our oxygen up to 100% when our compressions start. And then we're going to continue those chest compressions for a full 60 seconds before we even check a heart rate. So we want a good amount of circulation before we stop and check any kind of heart rate. So at that 60-second mark is a good time to switch out if you need to. Check on your friends, make sure that they don't need help or anything like that. I'm switching out. And then we can stop our chest compressions when our heart rate is less than 60, or when it's over 60, I'm sorry. but we continue our PPV at our same rate of 40 to 60. So this is just more of a visual of initiating our chest compression. So you can see the picture on the left, how the caregiver's thumbs are placed. We're right at that nipple line. You can even do, your thumbs on top of one another. You can do it at the side of the bed. You will learn in NRP and things like that, that they may move to the head of the bed. Wherever you are doing the most adequate chest compressions, stay there. If you're locked back in the corner and you're doing effective chest compressions along with ventilation, then by all means, we just need to stay there. So another skills practice. So I want you to practice your chest compressions coordinated with your manual breaths. So remember, we're using that cadence of 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe. And that will give you the ratio of the 3 to 1 that we want during CPR. Okay, so we're going to coordinate our chest compressions with our ventilation. 1 and 2 and 3 and breathe, 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 1 and 2 and 3 and breathe. Okay, next we're going to discuss initiating our IV access. So if you have given your positive pressure ventilation and now your heart rate still remains less than 60 and you've started chest compressions with your FiO2 at 100% and you've done that for a full minute, we know that we're probably headed towards code drugs. So we need to get some kind of IV access so that we can give those. The preferred method is an umbilical venous catheter. NRP suggests making emergent line kits. So all it consists of is your line tray, a 3.5 French or a 5 French single lumen UVC, and a normal saline flush. And this will be enough to get your emergent line in and fluid resuscitation if we should need it. When it's emergent in any kind of delivery room code, it does not have to be done sterilely. We just want that UVC to be placed just until you get blood return. So it may be as, 2 to 4. If we can't get an umbilical catheter in, say the baby's clamped down, has lost a lot of blood, we can still place an IO, even in our preterm kiddos. And then we are able to assist the physician. We can prepare that line kit, we can flush the line and prep the site for them. So administration of our epinephrine. Epinephrine is indicated if the baby's heart rate remains less than 60 after 30 seconds of our PPV and another seconds of chest compressions coordinated with our PPV at 100% oxygen. So our dosage, IV or IO or the venous route is 0.1 to 0.3 mils per kilogram. You're not going to take time to stop and weigh that baby. It's emergent, so it's a best guesstimate at that point. So let's take our baby that is 3 kilos. We could start anywhere from 0.3 to 0.9. And we're going to give that fast. We're going to follow it with our 0.5 to 1 mil normal saline flush. And we can repeat that dose every 3 to 5 minutes. You can give one dose down the ET tube at a higher dosage of our 0.5 to 1 mil per kilo, but it's just not quite as effective. So just knowing that epi given down the ET tube is going to be a little bit higher. So we take our 3 kilo baby, it can be anywhere from 1.5 to 3 mils that we're giving. So administration of our volume expanders. We're thinking volume expansion if the baby has any kind of blood loss. So if mom is an abruption, there's been a placental laceration, any kind of fetal trauma, a cord prolapse where that the blood supply has been cut off for some reason. these are those babies that you bring to the warmer. They have pale skin, they have terrible perfusion, very weak thready pulses, and the heart rate is not responding to PPV, has not responded to chest compressions, and even epi. So then you're thinking that, okay, the baby needs to have fluid resuscitation. Normal saline is our initial go-to, and that is given at 10 mils per kilogram and administered over 5 to 10 minutes. So we'll go back to our 3 kilo baby, 10 mils per kilo, we're going to give a 30 mil bolus. And again, we can give that over 5 to 10 minutes. If our baby is preterm, a little bit younger, we need to slow that down just a little bit. We don't want that big change in pressure or anything like that. You can give a second dose, but we may need to be thinking packed red blood cells at that point. If we know that there's been a blood loss, if our heart rate is not responding even to normal saline, then we need to probably be thinking about some kind of, our packed red blood cells. Epi is normally given first to get that heart rate up before we administer our volume expansion. You know that there's a blood loss, you know that you're headed towards giving normal saline, but we want to get that heart rate above 60 so that we can circulate that volume expansion. So one more skills practice, we're going to be drawing up epi, and I'm going to show you how to draw up normal saline. So for epi by the venous route, it's easier to be drawn up in a 1 mil syringe because it's such a small dose. And then epi given down our ET tube can be drawn up in a 3 to a 5 mil syringe. And then our normal saline can be drawn up in a 10 mil syringe or greater. So it sort of gives you, those different size syringes can help give it visually helps you differentiate between the dosages and the actual drug. But we always want to label our medications, and we always want to verbalize what dosage we're giving prior to administering it to the baby. So when we draw it up, we are verbalizing, we are verifying with the physician what amount that they want, the route that they want it. And then when you hand it over to the person that's helping you, we're going to do the same thing. We're going to verbalize and we're going to verify our dosages. So if you have started your chest compressions and you've given a full 60 seconds of your chest compressions and the baby still is not responding, the heart rate still hasn't come up, you're going to be thinking epinephrine. So we want the 1 to 10,000 of epi, and you can just open it from the bottom, and it's going to come in 2 separate pieces, just like this. So we want to make sure that we pop those 2 yellow ends off, just like that. And then we're going to screw this end until there's a rubber stopper in here. And so it will, we'll be able to screw that in. And then we'll take this yellow top off, the yellow piece. And then that is when we are going to attach our 3-way stopcock. And we'll attach it right there to the green. Okay, just like that. Looks like a T. Okay. And then we want to make sure that this is off to this end that we're not going to be using. And then depending on our dose, we'll attach that syringe here. Okay. So we've got our baby, we've got our line in here. And so you can push and pull at the same time. And then that will give you your dose. That will give you your dose. And again, 0.1 to 0.3 down the UVC, okay? So same thing with our ET tube. We've got our 5 ml syringe. We can attach it to the top, make her a little T, and then we can push and pull at the same time. And remember, the dose down the ET tube is going to be a little bit higher, so that's why we like to use the 5 ml syringe. For fluid resuscitation, the medication that we use is our normal saline, and it is 10 mils per kilo. So it can be drawn up or given in a couple of different ways. You can draw it out of a bag of your normal saline. You can use a larger syringe, a blunt needle, and you can draw your dose out of your bag, or pre-filled syringes, like the 10 ml pre-filled syringes. These are always nice to kind of use because you know that each one is going to be 10 mils that you can administer to that baby. It may be beneficial when you anticipate using epinephrine is to get all of your supplies and combine them together. It can be in just a baggie. We've got ours wrapped up with Coban. So you'll have your box of epi, you'll have your 5 ml syringe, your 1 ml syringe, and your 3-way stopcock, maybe a blunt needle. And then that way, the person that is assisting you, your medication person, all they have to do is grab the baggie of epi, or grab the code, if it's in a code box or anything like that, and it's all together. They don't have to fumble around and look for supplies. They're already there for you. And same thing with our normal saline. So we can have a small bag of normal saline. We can have our larger syringe, or even our pre-filled syringes, and maybe a blunt needle and another 3-way stopcock. Again, it allows your medication person or the person that's assisting you just to grab what they need and not have to look around for anything. Administration of other medications when having to do NRP or CPR on a baby. Other medications that you may hear, that you may have seen in the delivery room, you may see things like your sodium bicarb. It's not routinely given, but it may be a situation where you have to give that. Narcan, on the other hand, is not recommended for a baby in respiratory depression, just due to maternal opiate exposure or anything like that. There's not enough evidence to support the safety of this practice. It complicates, the baby can have other complications. And the main thing is we don't know mom's drug history. So if we administer Narcan because we think the baby has respiratory depression due to something that mom took, then we could potentially throw that baby into a full withdrawal. And it's just not worth that risk. Another medication that I want you to think about is surfactant. We definitely want to have that readily available for those babies that we anticipate are going to be extremely premature. You have a mom, she comes into labor room and she says that she's 28 weeks. If we have the potential to give surfactant, that's another medication that would be of benefit to the baby. So I'll touch on preterm infants and thermoregulation just briefly. We just need to remember to take extra measures for those babies that are less than 32 weeks. If we know that there's no stopping mom's labor and that she is going to deliver preterm, again, we'll go back to our mom that's 28 weeks. If we can get that room temperature turned up to above 74, it at least gets a warm environment. So when that baby's born, it's not born into a cold room, and we can maintain their temperature a little bit easier. It's difficult for our moms who have been laboring, or maybe they might be on MAG and they're hot, but it's about communication. It's just communicating the benefit to the baby. Our facility, we utilize what we call preemie packs. So it's a plastic turkey bag. Any kind of food grade bag would do fine. We have a chemical thermal warming mattress, small leads. We've got a triple layer hat. In your facility, even if it's a matter of just having a turkey bag and putting a couple hats on the baby, any extra measures that we can do to keep that baby warm is so, so important. Remembering to increase the radiant warmer temperature before the NRP team arrives. If we've got time, crank that warmer all the way up. And we just want to prevent any kind of rapid changes in our temperature. Also with our little preemies, we just want to handle them very gently. We don't want a whole lot of pressure changes to prevent intraventricular hemorrhage. So our IVH, we don't want to put that baby in a Trendelenburg position. We don't want to use excessive pressures if we don't have to. And like we talked about in a few slides before, slowing down our infusion rate for our IV fluids, slowing that down to the, maybe 20 minutes instead of 5 minutes. And then trying to transport all our babies, or, any baby, to whether it's special care or maybe they're getting transported to another facility, making sure that the baby's being transported in a pre-warmed transport isolate. And lastly, when it comes to doing NRP, it's important to stay calm. It's hard in situations like that. Again, it's not anything that you are anticipating. It's often a very emergent situation, and maybe one that providers don't experience all that often. And the adrenaline gets to running, and sometimes our emotions can get the best of us. So almost just like physically taking a deep breath and staying as calm as you can. If you have time, assign your roles. If you know that you're going to anticipate any kind of chest compressions or anything like that, you're going to need another set of hands. You have a buddy that comes and is, they'll be the medication person, and, somebody else is going to do chest compressions. Maybe RT is going to go ahead and do the airway. So it's just important to perform the tasks that you have either chosen or been assigned. I think as caregivers, we want to make sure everything's being taken care of. We want to make sure our meds are being, given right, or that somebody's doing chest compressions correctly. But then that takes us away from our assigned role. So it's just important to, if we can, we want to perform those tasks very well. Anticipate and plan. Again, a lot of times these deliveries, they happen fast. You're not expecting them. They happen probably at the busiest of times and maybe even the worst of times. But just planning for those scenarios, being prepared, having your medications prepared as a just in case. You would rather have it and not need it than need it and not have it. So it's planning for those worst scenarios, but hoping for the very best outcome. Knowing your environment, checking your equipment. You are familiar with your equipment, so I would rather you have 3 caregivers, a couple nurses, maybe a labor room nurse, mother baby nurse, or your respiratory therapist check all of your equipment than everybody assuming that, well, that person checked it and it not being checked. So we lose valuable minutes if we have to maybe get our suction set up. Our suction wasn't set up before we started resuscitation. Or maybe our CPAP wasn't on or something like that. So it's knowing your environment, checking your equipment, making sure that before that baby is born that you have everything that you need for the possibility of having to do CPR. Call for help when you need it. If you know that you are headed towards that more complex resuscitation, by all means, phone a friend. Have somebody, hey, can you call special care nursery? Can you call somebody from labor room? Can you make sure that you have another set of hands? Don't try to do it all. Make sure that you've got somebody there that can assist you. And then communication. It's all about teamwork. It's all about being an advocate for your patient. Again, it's very stressful. It's, when that adrenaline gets going, sometimes, you feel like you just are forgetting things, but communicate what you need, talk out loud. Let's say if you are having to do chest compressions, you're trying to coordinate that with your PPD. A lot of times it's a matter of everybody that is in that, surrounded that baby's bed is communicating the same thing, 1 and 2 and 3 and breathe. And it just, it dials it down just a little bit where, and then if you know that, it's verbalizing what you need and how to take, you've taken NRP, these babies. So it's about communicating what's best for your patient. And then if you do get a chance, try to debrief afterwards. I have learned so much just by debriefing, and it doesn't have to be anything really lengthy and let's all sit around a big conference room table and talk about the very beginning of the delivery all the way to when the baby transferred. It can be just a few minutes of can we talk about this for a second? What do you think went well? Where do you think we can improve? That's where we can improve our practices. What could we have done better? We didn't have, let's say it's a situation where the suction wasn't set up. So, it can be a change in practice so that that everything is all set up at all times. So giving every caregiver a chance to just kind of debrief and see what they felt went well and what could be improved upon is very beneficial.
All right, so we're back again and have our crew in the simulation center ready for some question and answer opportunities for all of you. I know that several of you are in a room together at your facilities. Maybe you're talking about some of these issues, but do you have any questions that you'd like to share with us now related to neonatal resuscitation? And I'm going to wait just a few seconds. And if you want, while you're thinking of those, Carrie and you guys at the Sim Center, do you have anything to add to the video?
I don't think so. I think just like I said at the end, it's in these situations, you guys are sometimes seeing things that you don't see all that often, or maybe you haven't ever seen. So just communicating the best that you can, what you need, and it's always about staying calm. I think we all can think about those situations, no matter if you do adults, whether you do babies, that you have maybe caregivers that heighten it a little bit, and how that makes us feel. So if you have a caregiver that's very it gets loud in there, it's it heightens that stress level, where, like I said, if you can just take that deep breath, kind of calm the environment down just a little bit, it makes it so much easier. You can think a little bit clearer. When it's heightened like that, it just really it makes it tough on everybody. And then just remembering your equipment. So just like JJ said before, if you can do little practice runs, or going back to your unit or the ER or wherever, and just checking out your equipment. We have here in the Sim Center, we have one kind of warmer, but then upstairs on Mother Baby, they have a different kind. So we make sure that all of our caregivers know how to use the warmer upstairs, up on Mother Baby, just because that's their equipment, that's what they're used to, and we want them to feel comfortable if they have an emergent situation like that. So getting your hands in there, checking things out is the best way to go.
Let me ask this real quick. So many of our listeners here are ER staff at these critical access hospitals. We have a few folks from Sullivan that have an obstetrical level department. But what kind of kits, what kind of supplies should they have in the emergency department to prepare for resuscitation?
The big thing is your oxygenation, whether you use a NeoT, you use a self-inflating bag, making sure you have different size masks. I think it would be beneficial to have your meds all in one area. So if you have your box of epi and your different size syringes all in one bag, and knowing where that is at. That I honestly feel like just your respiratory part, making sure you have a way to oxygenate the baby, and then if you need to provide the baby code drugs.
Okay. There was a question that asked to clarify the pretest question about thumb placement on nipple line versus lower part of the sternum.
So you want those thumbs just at the nipple line, and that if you kind of think of where the heart rests, that's going to give you your best compression and, you know, the ability to get that blood circulated around the body. If you're on that lower sternum, you know, you can, you know, think of it like even in an adult, you can cause damage to that sternum, and it doesn't give you the effective chest compressions you need.
Okay, great. Anything to add from our respiratory therapist there?
No, I can answer the next question though.
Okay, great.
Yeah, so I see a question there about a brief guidance indication for high flow oxygen for neonates. So high flow oxygen on neonates, commonly we're looking at, and if you agree with this, Thomas, it's usually greater than 2 to 3 liters. We see as it meeting or exceeding their inspiratory flow needs is the definition of high flow. And a couple things that high flow does do, it does cause a little bit of splinting of the airways, kind of like almost a hidden CPAP, which is good for recruiting some alveoli. The bad part is that you can't monitor them out, but it's usually in very low levels of 2 to 3 centimeters of water pressure from the things that I've heard. But high flow does work really well. I think not just for recruiting alveoli, but actually for stimulating the respiratory drive. So that constant flow and flushing out the anatomical dead space is really important in continuing the drive on kids that you have some transient apnea type issues. And instead of maybe calling it high flow oxygen, just high flow therapy. Because if you have the ability to put this on room air and run those flows at 4, 5, and 6, up to 8, and heat it and make it high flow, maybe in the terms of a Vapotherm or one from Fisher and Paykel. I don't want to get really specific with brands, but if you're able to do that on room air, it can be really efficient for stimulating that respiratory drive. So yeah, I think that high flow is very helpful. The best thing, the guidance that I can give you is to start high with the flow and low with the FiO2, and then taper down. You're not going to need as much FiO2 as you think, and we'll be limiting that anyway. But high flow does work really well when used. If you have that ability, and those brand name devices are expensive to set up. It's really not a billable item, if I think of it from a money standpoint. But then if you have the ability to have those work really well.
All right, thanks, Jimmy.
Yep.
Any other additional questions for our experts here?
You see the file up there.
All right. Well, we will continue on here with the third component of the training today, and one that I think is also very essential for what we do with neonates in your facilities, and that is stabilization, and one that it's certainly as important as the rest of them. So we will move on to this video here. I'm going to share my screen again and stop my video.
Hi, my name is Jennifer Jager. I'm going to be talking to you about STABLE. That's a method for preparing for resuscitation, stabilization, and transport of sick and or preterm infants. I'm the coordinator of our NICU graduate developmental care program. I'm a charge nurse in our level 3 NICU. I'm a neonatal outreach program educator, a member of our transport team, and also an instructor of NRP, PALS, and STABLE. So the goal of STABLE is to provide stabilization activities that are critical for the post-resuscitation and pre-transport care of sick infants. It's a mnemonic that stands for Sugar and Safe Care, temperature, airway, blood pressure, lab work, and emotional support. Stable follows the basics first. So it begins after ABCs, NRP, and PALS or PALS have been provided to stabilize your patient. The S in stable stands for sugar and safe care. An important point to know is that you should not feed an infant who is sick. They're at an increased risk for delayed gastric emptying. They're at risk for aspiration. They have poor suck, swallow, breathe coordination. So if you give them a bottle or let them go to breasts, they're likely going to aspirate. They may have abdominal distension. If they are hypoxic or hypotensive, that may result in reduced blood flow to the intestines. And it may even be necessary to withdraw a recent feed from the stomach if that's reported to you.
Give us a second here to see if the video is going to re-upload. My apologies.
Swaddle and papoose all infant and pull out any air intensive that may result in reduced blood flow to the intestines. And it may even be necessary to withdraw a recent feed from the stomach if that's reported to you. Also, if a bowel obstruction is suspected, you should decompress the stomach. The proper way to decompress the stomach or withdraw the contents of a recent feeding is to use a feeding tube. They come in various sizes, whatever you might have, you could probably make work. So you measure from the corner of the baby's nose, or if you're going to go in his mouth, from the corner of his lip to his ear with the feeding tube, and then you're going to find the point halfway between his xiphoid process and his belly button, and you're going to measure that. I get a 24 on this baby, and then I'm going to insert the feeding tube down to the 24 and just slide that down. When you get to the 24, you can use a tegaderm or a little piece of tape to adhere it to his cheek, and then you can attach a syringe and pull out any air for a round stomach or withdraw any feeding and discard that. You can either leave the feeding tube in to decompress later, or you can go ahead and withdraw it. Sugar and safe care again, we're going to provide glucose via IV fluids. The most successful IV sites for children and infants are their hands, feet, and scalp. If those attempts are unsuccessful, you want to use the intraosseous site. An IO drill is appropriate to use in the newborn and infant patient. Some IV pointers, you want to have at least 2 people present to start an IV on a child or an infant. Provide them a pacifier for comfort if that's something that they usually enjoy. Swaddle and papoose all infant and children, and then you want to move slowly as you're adjusting the angiocath because the blood return is going to be much slower on children than it is adults. This is one way to swaddle a baby so that you have an arm out that you might attempt to start an IV in his hand. If I wanted to attempt an IV start in a scalp, I might swaddle him completely. This is going to help him feel contained. It's going to keep him warm. It's going to make him feel secure. And it also keeps him from moving too much. If you would like to start an IV in the scalp, babies have excellent scalp veins. You can use like an office rubber band to put it around the eyebrow to help your vessels stand up. And then you should point the catheter down towards the heart. So they frequently have a big one behind their ears, so I would go at this angle. The They usually have one right in the center of the forehead, and again, you would go down. So any one you find, you'd be pointing down towards the heart would be the proper placement. Newborns that are going to be at risk for hypoglycemia, babies that are preterm, anything less than 37 weeks is considered preterm, so you'd want to be prepared for that. A baby that's small for gestational age, large for gestational age, those babies are at risk for a low blood sugar. If you're unaware of what might qualify as SGA or LGA, I frequently use Google on my phone to have information quick at hand. Babies for an infant of a diabetic mother and any sick infant is going to use more glucose than normal. Signs and symptoms of hypoglycemia include an abnormal cry, a low temp, tremors, irritability, lethargy, tachypnea, cyanosis, poor sucking coordination. They're going to be sweaty, jittery, hypotonia, seizures, and maybe even apnea. Stable recommends the goal of therapy to be 50 to 110, and this is a little higher than the American Academy of Pediatrics, but their goal is babies that are staying in the same facility with their mother. Stable's preparing for a baby who is post-resuscitation and pre-transport to another facility, another floor, those kind of things. So you want the goal to be, you want the sugar to be a little higher. Initial IV fluid management of a sick infant, because we've established that we shouldn't feed them, so we can't raise their sugar that way. D10 at 80 milliliters per kilo per day, and you always infuse on an infant or a newborn using a pump. So D10 is your fluid of choice. To treat a glucose less than 50, you want to give a D10 bolus. So 2 cc's per kilo of a D10 bolus at 1 milliliter per minute. So we have an example of 4 kilogram baby with a blood sugar of 38. We would initially start their IV of D10, and we've done the math. And that means we're going to set our pump at 13 cc's per hour. In addition to that, we're also going to piggyback in a little bolus of 8 cc's of D10, and it's going to run over 8 minutes. 15 to 30 minutes after that bolus is done, and you can, again, use your phone to set a timer, you want to recheck the glucose. If it is again less than 50, you want to repeat the 2 cc per kilo bolus. So we're going to give another 8 cc's in our example, and we're going to run that over 8 minutes, and we're going to do the math and increase our infusion to 100 cc's per kilo per day. We're going to set our timer again, recheck in 15 to 30 minutes after that bolus is complete. If that sugar is still less than 50, repeat your bolus. You want to increase your infusion to 120 cc's per kilo, or you can increase the dextrose concentration to D12.5 and run that at maintain it 100 cc's per kilo per day. It is possible to go up to D15, but no, the highest concentration for a peripheral site is D12.5. If you're going higher than that, that will require a central line. We're moving on to T for temperature. Hypothermia is a preventable condition, so we should make sure we're doing all we can to prevent hypothermia. It has a well-documented impact on morbidity and mortality. Your baby's chances of dying are much greater if they are cold at any point, and this is especially true for premature infants. Maintaining that normal temperature is a priority whether the baby's well or sick. Things that put your patient at risk, increased risk for hypothermia, is prematurity, a low birth weight, infants that are undergoing a prolonged resuscitation because you're blowing cold oxygen flow directly into the heart and lungs where it's going to cool the blood that's being pumped all over the body. And also infants who become acutely ill. People at risk, infants at risk for hypothermia include premature babies, low birth weight babies, prolonged resuscitation, especially if hypoxic, for the reasons I said before, babies who are acutely ill with infection, cardiac, surgical problems, and then babies who have decreased activity or hypotonic. They're not moving around, they're not staying flexed to have that muscle activity that's going to create heat. What's the normal temperature? In Celsius is 36.5 to 37.5, and in Fahrenheit, 97.7 to 99.5. That's your goal. So proper thermometer placement, axillary, axillary, axillary is the best place to take a temperature. Ways that you can maintain or increase temperature is placing the baby skin to skin. And as you can see in the picture, it's important the baby goes vertical on mom's chest between her breasts. The baby should have at most a diaper on, maybe a hat. Mom needs to be bare-chested with no shirt or bralette so that baby's chest is against mom's chest. You can use a radiant warmer. Remember that on a radiant warmer, the temp probe is going to be placed over the liver, and you want to set that to servo control or baby mode. A good starting place is 36.5, but you want to check the baby's temperature with an axillary thermometer frequently, every 15 to 30 minutes while they're on the warmer, and they can only be wearing a diaper on the radiant warmer. It needs to allow the heat to get to their skin in order to heat them properly, so no clothes when they're on the radiant warmer. They can wear a hat. Swaddling, like the baby in the bottom left, is appropriate. When they're swaddled, the warmer should not be on, but keeping the baby in a flex position keeps them warm, and then layers of blankets also is going to help keep heat in. Also know that a baby who's prone and flexed is going to keep them warmer. You can put them prone and flexed on a radiant warmer, but then you would need to put your heart, your gold heart or your temp probe up towards the radiant warmer where it can pick up skin temperature on the side that's facing the heat. So again, a reminder, when the baby's on the radiant warmer, no clothes. They can wear a diaper, and a hat is a good idea. You want to make sure the baby's under the heater. Sometimes during resuscitation or procedures, they get pulled towards the foot and their head is not under the heat source anymore. So keep them under the heater, centered, and the temp probe goes over the liver area where you're going to have a lot of blood flow to get a pretty good core temperature. You want to set it to baby mode or servo control. 36.5 is a good starting point. And remember, no clothes when they're under the radiant warmer. Give them a hat. So cute little picture. A hat is always a good idea in a newborn or a baby who's in a facility where it may be cooler. If you have a baby who was born in your facility, you want to make sure you get wet blankets from the amniotic fluid away from them. So dry them off, get the wet blankets. Even an infant who's just in your facility because they're sick, maybe they've spit up or the diapers leaked on the blanket, you want to get wet linens away from them. That's going to bring their temperature down. Moving on to airway, and that's going to be covered in another segment by our respiratory therapist extraordinaire, Jimmy McCann. We're moving on to the B in stable. That stands for blood pressure. So here we're going to talk about shock. It's just to remind you to assess blood pressure. For cells to survive and function, they need oxygen. So there's a state of shock when there's inadequate tissue perfusion and oxygen delivery to all the vital organs. There's two phases of shock, compensated and uncompensated. In compensated, blood flow is diverted from non-vital organs. So as we mentioned before, the intestines may not be getting as much blood. The skin may not be getting as much blood. In this state, blood pressure and blood flow to the vital organs is maintained, so heart, lungs, and brain. If this shock isn't quickly recognized and reversed, it leads to anaerobic metabolism that then leads to lactic acid accumulation. It's going to cause the pH in your blood gas to become acidotic. That's going to lead to cardiac output and eventually death. So you must reverse the stages of shock. Uncompensated shock is when the baby's moved to a point where their normal blood pressure is no longer maintained. Physical exam findings that are indicative of shock. Some of these are the same things we saw on a baby with low blood sugar. Tachypnea, apnea, cyanosis or DSATs, bradycardia, which in an infant newborn is less than 100 beats per minute. a blood pressure that's too low, poor perfusion where their cap refill is greater than 3 seconds. On newborns and infants, you're going to check capillary refill in the middle of their forehead or in the center of their sternum or on the top of their tibia. You're not checking out at their fingernail beds. You're going to watch for cool skin, decreased urine output, increased work of breathing. They may have gasping if it's severe. They have pale or white skin color. They may have tachycardia, where their heart is working fast to compensate. Weak peripheral pulses. When you look at the chest x-ray, the heart's enlarged and mottled skin is frequently seen. So there's 3 types of shock, and what type of shock you think you may be dealing with helps determine treatment. So you see in the picture, this baby is pale, they have low tone. If the picture were a little more clear, maybe they have mottling. And you see, obviously, there's intubated, so level of consciousness, work of breathing is not maintainable right now for the baby. The 3 types of shock are hypovolemia, cardiogenic, and septic. In hypovolemic shock, you have low circulating blood volume. So there's several causes listed there, and if the baby's born in your facility or was born shortly before they arrived, the history from mom may give you a clue that that's the cause of the shock. So a lot of moms will know if they have a previa and can tell you that. Maybe if you were present for the delivery, you know if it was an abruption, brain scalp or lung hemorrhage. In the picture, you see a twin-to-twin transfusion where there's been some problem with the blood flow between the placenta and the baby. So one baby received all the blood and the other didn't get so much. An umbilical cord accident, that the cord may be compressed somehow during delivery. That's different than an umbilical cord injury where maybe the cord was torn and the baby bled from there. Cardiogenic shock, that's when the heart muscle functions poorly. That can happen with an intrapartum or a postpartum asphyxia. And again, that could be a cord accident of sorts. Hypoxia or metabolic acidosis, that can occur with infection, severe respiratory distress, very low sugar. In arrhythmias, which most commonly you're going to see a kind of congenital SVT or a congenital heart disease. Septic or distributive shock is a third kind. In that situation, you're going to have loss of vascular integrity. So the blood vessels in the baby have lost their tone and they leak blood into the tissue beds. There's going to be poor muscle contractility, which leads to poor tissue perfusion and oxygenation. These infants need fluid resuscitation and blood pressure meds. Treatment of shock, the number one is to identify and figure out its cause or causes if there's multiple. And then the next thing is to correct any underlying problems or related problems that are impairing the heart function. Treatment of hypovolemic shock. So you want to improve the circulating blood volume. If you know that there was no acute blood loss, but your baby appears shocky, you want to administer 10 cc's per kilo of saline over 15 to 30 minutes. So you want to do that on a pump. If you know there was an acute blood loss, there was an abruption, there was previa, the cord clamp came off and the baby lost blood through their umbilical cord, you want to administer packed red blood cells or whole blood, 10 cc's per kilo over 30 minutes to 2 hours. If you're dealing with cardiogenic shock, you want to correct the underlying problems. So hypoxemia, give them oxygen, hypoglycemia, normalize their sugar, hypothermia, get their temperature appropriate, hypotension, give them fluids, acidosis, arrhythmias, if that needs to be corrected, infection, you want to start treatment early, and if the baby's experiencing any electrolyte imbalances, you want to correct those. Treatment of septic shock, many fluid boluses. So you're going to be repeating that 10 cc's per kilo. You're going to reassess and then administer another bolus if the baby's signs of shock haven't improved. Dopamine is also good treatment for septic shock, and you want to optimize oxygenation and ventilation. So assuming you have a transport team coming, you may consult with the expert to get advice on whether your baby should be changed from nasal cannula to CPAP or CPAP to intubated, and go from there with that information. L is for lab work. So you may need to be doing some lab work. Neonatal infection is devastating to an immunological immature baby. Their immune system is very immature, and it puts them at increased risk for acquiring and succumbing to infection, and it happens fast in a matter of hours. The signs of sepsis may range from subtle and nonspecific to mistakenly apparent. Best practice, give antibiotics to any neonate has any signs of infection. So your subtle, nonspecific signs, which these are strikingly similar to some of the other clinical findings that we've seen: respiratory distress, apnea, tachypnea, tachycardia, and forced skin perfusion. And that's a great example in the picture of modeling in a newborn. Clinical signs of sepsis, all those, like I said, we've seen before. Temp instability, frequently newborns who are septic are cold instead of running a fever, so be aware of that. Again, we've talked about tachycardia, bradycardia. They might be feeding, they quit eating at home, they threw up all their feedings. All these things we frequently see. And then obvious signs of infection, maybe there's blisters, or you see some soft tissue swelling, redness, maybe from their recent circ, maybe from their umbilical stump. Some lab evaluation that's important to have and can be started prior to transport: a CBC with a differential, a blood culture, a blood sugar, and a blood gas. So blood count, blood culture, blood sugar, blood gas. Antibiotics started early are imperative. Of course, you want to get your blood culture first. Recommended antibiotics that will cover a huge percentage of the infections that affect neonates is ampicillin and gentamicin. The doses are there. AMP is 50 milligrams per kilo over 5 minutes every 12 hours, and the gent is 4 to 5 milligrams per kilo per dose, and that interval is every 24 to 48 hours, depending on the baby's gestational age. So you can give the first dose and then let the experts decide what the interval will be. E in stable stands for emotional support. A sick or a preterm infant is a major crisis and shock for families. They all have pictured in their mind a perfect birth and a perfect baby. And when that isn't happening, it is very difficult for them. Some of the emotions you may see, a sense of failure. Moms feel their bodies have failed them if the baby's born early or there's a cord accident of some sort. They may be quiet and fearful and sad, or you may see someone who's angry. So be prepared for anything. When the transport team arrives, frequently the parent's not able to go on transport with their baby. So it might be good for you to accompany the team and listen to an explanation of the condition so that you can repeat that to the parents or help explain it further. You want to expect them to have a hard time recalling the information, and you may have to repeatedly explain that. If you have any material or illustrations to give them, and then it's good to help them think of questions, write down questions. Sometimes they're just too distraught to think clearly. After the transport leaves, if you are a delivering facility and you're keeping the mom with you, you want to encourage and assist with pumping. You want to facilitate communication between the parents and the staff caring for the baby. So getting phone numbers, or maybe even calling yourself to check on the baby to make sure that they arrive safely and let the parents know that. If you have social services available at your facility that can assist with transportation, gas cards, cabs, maybe some meals, or lodging if possible, just to facilitate, this is likely something they were not expecting at all. It becomes an emotional and a financial burden. So in conclusion, you want to address all the points of stable post-resuscitation and in that pre-transport time with your infant to improve all your outcomes. Thank you very much.
All right, so thank you very much for that. I'm going to answer some questions related to stable now. So again, if you'd like to, please send us some questions either through chat or go ahead and answer them now. Jennifer, who completed this section, she is working in the NICU today. She actually is on the line on her phone, but I'm not sure if she's able to join us right now or not, just depending on how things are going in the NICU. But we do have Carrie Stewart on here, who's also a stable instructor who can answer some of these questions. So any questions for our group related to stabilization? So I asked a question to the group just a little while ago via the chat, how long it typically takes for the NICU transport team to arrive to your facility, and it probably varies from hospital to hospital. So resuscitation obviously has to take place immediately upon birth, but stabilization is just as important, and any delays in the transport team arriving make it very critical to complete stabilization. So Carrie or Jen, can you talk a little bit about what steps are probably going to need to be taking place as the hospital is waiting for the transport team to arrive? Go ahead, Carrie, if you'd like to.
I feel like all of our facilities that we have actually gone to have done a excellent job at stabilizing those kiddos. Again, it's not something that you guys see a whole lot, but the transports that we have been on, they do an excellent job. I think maybe one thing might just be thermoregulation. Just like Jimmy said in his video, a cold baby doesn't breathe. So that makes it difficult. And I think it's hard when you're outside of a labor room or outside of, if you're in an ER and things like that, to keep a baby warm. So just doing those small things, even if you put, a couple hats on them, or even term infants, you can, cover them. Years and years ago, we used to use saran wrap and would literally place that over the baby to kind of keep that heat in. So I think if anything, it would probably just be, keeping the babies warm, warm blankets, putting them on warm blankets, putting them skin to skin with mom, that does wonders for a baby. So, if the baby's stable and can be skin to skin with mom, then by all means, put that baby on her chest. So I think that would probably be the only suggestion I would probably have. I don't know how the rest of the group feels, but.
What about in terms of the warmer? Are there any specific things that you're seeing with how the warmer is handled during the interim time between transport team arriving and the baby's birth?
Keeping the baby on servo, so then that way if the baby is cold or if the baby's even getting too hot, remembering to hit that warmer on servo, so then that way it's serving the baby essentially. Instead of what's manual, where we crank it all the way up, but just remembering when we put that temp probe on to put it on servo, so then that way it's baby's not getting too hot, but also not getting too cold. So, and sometimes that's difficult because you do have the baby's wet, or you know, maybe still has quite a bit of vernix or something like that. So it's hard to get that to stick, but, you know, keeping the baby underneath where the heat comes down from, and, you know, just using the servo mode.
Gotcha. Are there any particular issues that any of you at your hospitals are seeing that you'd like to discuss? All right. So if there are additional questions, please, again, I'm repeating myself a lot, put them in the chat. We're happy to answer them. One question that came up earlier that we were talking about with the, regarding the pretest, and the answer to the question on the pretest, which of the following best describes the appropriate thumb position for neonatal chest compressions? And the answer that we had in there is both thumbs on the lower half of the sternum. So Carrie, can you kind of explain that? Again, maybe the question is not worded very well, but maybe describe exactly what we're talking about here.
Yeah, so I actually am just gonna read straight from the book, so there can be a little bit of clarity, I think. So you're gonna be on the lower third of the sternum. And you're placing your, so if you have that imaginary line across the you know, what we call the nipple line, just think of the nipples as landmarks. So, you know, your thumbs are gonna just be, I don't know how, this is something right there.
We'll be able to see it very well.
Yeah, right there.
Yep.
My God. So, you know, we've got our nipple line here, and our, you know, we just want to stay off that xiphoid right there. But if you're just like the top of your thumbs are just at that nipple line, I'm just below it. So my nipple line's here, my thumbs are here. That's where you're going to get your best compression. Does that clarify it a little bit?
Yeah, and so on the post test, you'll see this question again. I went ahead and put on there that either of those answers would be considered correct, just for the post test portion. But keep in mind what Carrie said. That's what we're looking for when we're doing compressions. And any additional questions, again, please go ahead and answer those in the chat. And we're going to go ahead and go on to our two simulation scenarios, and please watch these and try to pick out any things that you see that you want to ask questions about, because we'll have a debriefing session again after this video to kind of talk about each one of these. So we'll go ahead and start with the next video, and I'm going to again share my screen and take my face off the video. I'm going to start here.
We're prepared.
She's 35 weeks in clear fluid.
All right, thank you.
Big push.
Big deep breath.
Big push. Good
Push,
job.
Push, 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 push,
Good
push.
job.
Almost there.
Big push.
Just try and get his shoulders past it. Big deep breath and push. Bear down and push.
Good job, Olivia. Good job, Olivia. Big push.
Almost there. There we
Good.
go. Here he comes. Here he comes. And time.
Good. Cord clamp. Cord is cut.
All right, stimulate.
We're at 30 seconds. I'm going to listen for heart rate.
Okay.
Have a little bit of respiratory
Painting.
effort.
Yeah, a little effort.
.90.
Okay.
A little bit for help him out a little bit.
There's some grunting.
Some grunting.
Grunting. I'm gonna apply CPAP about 5.
How much
Much
FO2 are we on?
Right now I'm on the wall, so I'm 100%.
Okay.
The blender I would be down as low as I could
Good
to maintain a
oximeter on his right wrist.
maintain adequate saturation.
Get a little shoulder roll for him.
Yeah, sure, that'd be great. Yeah, thank you.
Get his airway open.
Perfect. Good.
Yeah, heart rate's coming up nicely.
Great. Great. I'm gonna continue CPAP here to increase alveoli. Give him a little bit of help.
He's got good chest rise and fall.
Yeah,
120s.
much better effort.
Got good air entry on both sides.
Let's decrease our pulse ox. FiO2 is decreasing.
And the guys breathe a little bit faster.
Good. Pulse ox on the right wrist. 87, 88 is trending
Saturation's
upwards.
coming up.
Good job. Cover your breathing.
Still sounds like you might need a little bit of help here with CPAP.
I'm gonna scoot him down just a little bit so it's fully under the heater.
Okay.
Put 10 probe on over his liver. Set this to servo mode. Start at 36.5.
Some more response.
There's some bitter grass.
Coming up on 3 minutes.
Okay, so birth time was about 3 minutes ago. We'll want to check a sugar, a glucose at about 30 minutes of age. So we're getting his sugar and not mom's.
That's his capillary refill, Jen.
About 2 to 3 seconds. Pretty good for, don't need to do any fluid resuscitation. There's no history that indicates he had any bleeding.
Pulse ox now is 92.
Great. We'll start weaning up FiO2.
Got a good seal, we're getting good color.
So we're gonna need a blood gas, blood cultures, CBC.
Okay. We want to make sure, since we're not going to be keeping him here, we want to make sure we get contact information for the NICU he's going to, so we can share that with mom. We'll want to get some pictures and video for her before he goes. Hopefully we can get him close enough so she can at least touch him.
Still maintaining CPAP about 5. FiO2's room air.
Excellent. If his sugar's low when we do that, if it's less than 50 at 30 minutes of age, we'll work on getting a peripheral IV for the transport team, but they should be pretty close to being here by then.
Excellent.
All right, let's go ahead and talk about this situation a little bit. And Jimmy, Carrie, and Thomas, would you like to kind of start us off here?
Yeah, so let me scoot up a little bit. This is one of our standard simulations that we do here in the simulation center, and when we do it on site. It's just a child with some respiratory depression, and so doesn't necessarily isn't indicated initially for positive pressure ventilation, but we just apply CPAP and recruit alveoli during that time. Watch the heart rate increase, and then a real key to this is not necessarily just the resuscitation of their initial respiratory issues. It's all of the additional things that go on as far as temperature regulation, blood sugar, setting up for transport, and so those are all every little thing that Jennifer says in that is what we look for in our simulation to know that the team is on board for not just the initial care, but then the follow-up, which is way more important, because I think all of us can do the initial care, but it's knowing what comes next, which is vital, especially if you don't do something very often, because you kind of get to a point like, what do we do now? We've called, and what do we do? So this is kind of a little more, a little easier simulation as far as resuscitation goes, but we really focus on the follow-up aspect. Anything you have, Carrie?
Just to add what Jimmy was talking about too. So in the video, the baby is grunting, which we know is not effective respirations. Their aeration is not good. So it's not only going to be a respiratory issue, but just like Jennifer said in her video, if the baby's cold, they may start grunting like that. If the baby's blood sugar is low, they may, start grunting. So you're doing all these things. You're like, well, I'm getting, good movement. Why is my baby still grunting? You may need to, check a sugar, and also, check a temp, make sure that they're staying warm and their blood sugar staying up.
Great. Does anybody from your individual hospitals have any questions related to the simulation?
I do have a funny story that we did at one time, just real short, but just recognizing, because when that simulator comes over initially, it usually isn't grunting. But I know there was one scenario that we had done, and it wasn't it was some other place that we did it, but it was funny because the clinician said, oh, we're okay because the baby's cooing right now. And so it was kind of a funny moment. The baby's cooing, it's okay. And we were like, oh. And so we couldn't stop the simulation. So it was a good teaching point later that was grunting, and they were fighting for their breath, but it sounded like they were cooing. So anyway, it's just kind of a funny story.
And sometimes those are the babies that they'll be sitting, they're on the warmer and they're grunting like that.
Yeah.
Grandma comes over and is like, oh my gosh, they're singing to me, or they're talking to me. And so
That was a scenario.
You may hear those things too.
Yeah.
That it's not a good thing. So
No cooing simulators.
no.
Yes.
All right, well, let's go ahead and move on to our second simulation. And I'm going to, again, get this moved over.
Good job, Olivia. Keep pushing. Keep pushing. Good job.
Well, set the
She's
warmer
full
up.
turn. She's
Okay.
full turn.
Big push.
Clear fluid.
Big push. Good.
Right on.
Good. Good.
Job. Time.
We have a true knot in the cord clamp.
I'm starting.
Time.
Cord is cut.
All right. This is where I stimulate. Okay. Very, very unresponsive.
Yeah. Yes, they went for a shoulder roll.
Yeah, so shoulder roll, start some PPV. Got pressures of 20/5. We're going to start at 100% FiO2.
No respiratory effort.
No effort at this time.
Yeah, I'm not getting any pulse. I can't feel in or heal on. Wait till we've done 30 seconds of PPV. Got good chest rise with your breaths.
Yeah, we got pressures are
Good
coming up
air
on our
entry.
manometer.
Okay, there's our 1 minute. We'll reassess. I still don't hear anything, guys.
Okay, let's start compressions.
Okay.
We're on 100% FiO2.
Okay.
1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1
I'm gonna
and 2
get your
and 3
intubation
and breathe.
equipment ready, Jimmy.
1 and
Thank
2
you.
and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and
Still
3 and breathe.
100%.
1 and 2
20 over
and 3
5.
and breathe. 1 and 2 and 3 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 and breathe.
Impressions.
1 and 2 and 3
Good
and
chest
breathe.
rise.
1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2
Okay, we're
and
going
3
to do
and
this in 2
breathe.
minutes.
Yep.
Let's reassess. I'm going to intubate. Check it. Capnography. Colorimetric change. We have good change. CO2 is present. Okay. 3.5 ET tube.
Impressions, yeah.
We're going to say this is a
Stethoscope there.
3 kilo child. 6 plus 3 is 9. We're going to secure it at 9 at the lip.
And 2 and 3 and breathe. 1 and 2.
Let's confirm it also with end-tidal CO2.
I'm gonna get an IO ready.
We have change on our
1 and 2.
CO2 indicator.
What are we estimating the weight?
1 and 2 and 3 and breathe. 1 and 2 and 3 and
You guys
breathe.
think
3 kilos.
3 kilos.
Breathe. 1 and 2 and 3 and
I'm gonna
breathe.
drop 0.1 to 0.3 cc's per kilo of epi, so that'll be 0.3 to 0.9. I think I'll just drop 0.9.
1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1
Good
and 2
pressure
and
on our
3 and
manometer.
breathe. 1 and
Good
2
chest
and 3
rise
and
with each
breathe.
breath.
1 and 2 and 3 and breathe.
Remain on
1 and 2
100%.
and 3 and breathe.
Does everybody agree with my math? 0.9 cc's of epi for a 0.3 kilo baby.
1 and 2 and
Confirm
3
that.
and breathe.
0.9.
2 and 3 and breathe. 1 and 2 and 3
Do you have a
and breathe.
flash, Dr. Thomas?
3 and breathe.
I do. Yes, I do.
I'm gonna go ahead and prepare a 10 cc per kilo bolus.
3 and breathe. 1 and
So it'll
2
be
and
30.
3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and
All right,
3
sharp
and
coming in.
1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. And 2 and 3 and breathe. 1 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 and 2 and 3 and breathe.
Positive marrow
2
return.
and 3 and breathe. 1 and 2 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 and 3
Io's in
and
at
breathe.
4 minutes of age.
2 and 3 and breathe. 1 and 2 and 3 and breathe. 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2
Flush is
and 3
good.
and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe.
I'm gonna reassess and see if we still need to give epi.
I'm gonna remove the needle.
Heart rate's still below 60.
Good chest rise with ET2.
1
Okay.
and 2 and 3
I'm
and
gonna
breathe.
push epi.
1 and
We're at
2
4
and
minutes,
3 and
45
breathe.
seconds.
1 and 2 and 3 and breathe. 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 1 and 2 and 3 and breathe.
5
1 and
minutes.
2 and 3
60
and
c
breathe.
flush after
1
that.
and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2.
Our sounds are still equal.
1 and 2
our
and 3
perfusion.
and breathe. 1 and 2 and 3 and breathe. 1
should go ahead and give the bolus.
3 and breathe. 1 and 2 and 3
20
and breathe.
cc's of kilo
1 and
per
2
kilo.
and 3
10
and
cc's per kilo.
10 cc's per kilo. Yes, thank
1
you.
and 2 and 3 and breathe. 2 and
Push
3
that in.
and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe.
Here's the last
1
10.
and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. 2 and 3 and breathe. 1, 2, 3 and breathe. 2 and 3 and breathe.
Bolus
2
in.
and 3 and breathe. 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe.
So we can give next dose of epi at 7:45 every 3 to 5 minutes.
3 and breathe.
End-tidal CO2's at 40 now.
1 and 2 and 3 and breathe. 2 and 3 and breathe. 1 and 2 and 3 and breathe. 2 and 3 and breathe. Our heart rate's above 60.
Temp probe on him, set it to servo control.
Ventilating at 40 per minute.
Yeah, heart rate's about 110, 115.
Hold compressions.
Good chest rise.
Yep.
Secure the CT tube.
Our sounds are still equal.
Are there any spontaneous breaths anybody can see?
Negative.
Okay, well, we want to check his sugar. We want to make sure we keep him under the heater and keep the heat unblocked since he's getting all this cold air blown in around his heart and lungs to maintain his temperature. His airway's stable, and we'll make sure we tape that. Maybe get a chest x-ray for tube placement. We gave him a bolus. We want to recheck perfusion, see if we need to repeat that bolus. We can draw labs for the transport team. What all do we need to get?
Let's get a CBC, blood gas, and let's get blood cultures as well.
Okay. We want to make sure we get mom close enough to touch him, let her get some pictures and videos, help her with communication between the transport team and her, exchange phone numbers and all of that. So we'll go see if the transport team's here.
All right. Well, again, we apologize for the herky-jerkiness of the video. When you're dealing with technology and a live video stream, sometimes that stuff gets screwed up a little bit, so we apologize for that. I will tell you that all of our videos are available for you to watch, and we'll send out a link to this entire training to each of your facilities. But currently, all those videos are online on YouTube on the RHIC Simulation Center channel. So you can always just type that in and go to our page and watch any of these videos, or really any of the videos that we have for any of our trainings are on there. So please do that at your leisure. But let's talk about this scenario a little bit. So team at the Sim Center, can you walk us through what was going on with this baby?
So we had a mom that came in and delivered emergently. It was abortion, right? Term. So baby was born, had a true knot. So, you know, we know that there was no blood flow, you know, at that point. So cord was clamped, took the baby over to the warmer and wasn't initially doing anything. Gave some breaths, PPV for 30 seconds, checked our heart rate, and it was not responding at all to, you know, our respiratory attempts. Started chest compressions. Did we increase our FiO2 to 100%?
Yes.
Yeah. And in the video, you can see where Jennifer does her chest compressions for a full minute, and then she's asking for help. So when you're to that point, if you know that, you know, you're starting chest compressions, by all means, you know, make sure that you're calling out for help, or hey, can you call somebody to at least write for me or be my second set of hands. And then that's when another caregiver stepped in, swapped out, started doing chest compressions with coordinated respirations. And we were anticipating, since there was that no blood flow, we were anticipating that this kiddo was going to need volume expansion. So drew up our meds. And again, you know, going back to when we do draw up our meds, just like in the video, just like anything you've done, it's your best guesstimate. So you're not going to stop and take the time to weigh your baby. And I think as providers, sometimes we get pretty good at, you know, yeah, the kid's 3 kilos or 2.5, and then basing it off of that. 3 kilo baby, we, you know, gave a dose of epi, and then gave our volume expansion right after that.
Anything additional, Jimmy or Thomas?
Yeah, I'll address the question from Sarah up there about the compression to ventilation ratio. So our recommendation is that you maintain the 1 and 2 and 3 and breathe. It does a couple different things, even after the tracheal tube's in. In the adult world, once you hit the tracheal tube, the mask airway goes in, you can go asynchronous, do your compressions, do your ventilations. But in the neonatal world, I think that we're dealing with, if we do a compression and a breath at the same time, it's going to negate both of them. And when we're basing everything not on the 2 minutes, but on shorter amounts of time, I think that we need to make sure that every compression and every breath gets its due time, I can maybe say. So staying coordinated, I think, is real important. And for the person that's doing the ventilation, if it's the RT, the nurse, the physician, whoever is doing that, to keep them kind of in sync. So, and the thing about a T-piece resuscitator that's a lot different than a self-inflating back valve mask is it's not very laborious to use. And so you really have a tendency to stop moving your finger appropriately. I don't know what it is, but we've just seen that. If you're using a back valve mask, you know, just the act of squeezing kind of keeps you in rhythm. But when you're using a T-piece and you're just going like this.
Jimmy, can you get it a little closer?
Oh, yeah, sure. Yeah. So, of course, using a self-inflating bag, doing this motion kind of keeps you in rhythm quite a bit. And a lot of us that have worked with airways for a while, we're kind of used to that. We've done it in the adult world, we've done it in the neonatal world. But when you go to just the T-piece resuscitator and you're just occluding that, there's really a tendency to miss breaths. And so the 1 and 2 and 3 and breathe really is kind of your indicator to make sure that we're staying in line, even though we have an endotracheal tube in. So it is our recommendation that you continue to count and count out loud. And also another thing we feel is really important is that only one person counts. So Carrie doesn't say 1 and 2 and 3 and I say breathe, because we've got to have perfect rhythm for that, and rarely anybody does. So having one person continuously count is really important, and even when the endotracheal tube's in. But that's a really good question, because pediatric and the adult, I know adult world for sure, and pediatric world, once the endotracheal tube goes in, you go asynchronous, you just kind of do your own thing. But we try to stay synchronized with neonates.
Gotcha. Thomas, would you, so we put in an IO during the simulation. Would you address that a little bit and talk about why we would do that in this situation and some of the technique stuff that you implemented during that?
Yeah, absolutely. One, it's a very busy scenario, and I hope everybody quickly observed how clear and calm the communications were, because I believe communication in those scenarios is extremely important. And so specifically, JJ, your question about the IO, IOs are awesome. And remember that any medication or any fluid given IV can be given IO, whether you're talking about a newborn or whether you're talking about an adult. And the IO is kind of looked at, one, it's still kind of new and a lot of people are unfamiliar with it. We all need to get a lot more comfortable with it and utilize it more often. It's extremely fast to insert. It doesn't take the extreme precision as an IV does into their little veins with neonates and newborns. And you saw in the video in the scenario how quickly it can be put in, and that was not exaggerated to any degree. That's in real time, real life, how fast one can be placed, and then you have access to give medications as well as fluids without a second or third and sometimes even more attempts in those situations. So please look to IOs quicker and utilize them more often. Remember, they only stay in for 24 hours, and if we get it, they kind of get us over the hump. And then after we get the patient stabilized, we can look for a more long-term access point and remove the IO.
Okay, great. I've placed a lot of IVs in adults in code situations. And that's challenging enough. I can't even imagine how hard it is to try to find an IV on a baby as small as a neonate. So, Carrie, you probably can share a little bit about how challenging that is.
It definitely is challenging. And I think too, when a baby is born emergently, there's a reason for it. So, you know, if they're shocky or anything like that, you know, all the blood is shunted to the core. So they're in survival mode. So trying to find an IV can be a bit of a struggle. So, you know, having access like an IO or an emergent line is definitely a plus.
Yes, and I mean, you guys do it in the NICU all the time, but ER staff, they're probably not used to doing this on a routine basis. Lord knows there's no way I could ever start one on a baby. So yeah, I think the IO is a good idea. Does anybody else have any questions for our group here right before we end with the post-test and the evaluation? Or any comments? How you're doing things at your facility? And one of these times I'm just going to wait you out and until somebody finally answers, but I just don't have the gumption to do it, I guess. Okay, well, I'm going to share here the screen so we can do the post-test and evaluation. Also keep in mind, or if you want to, I did post it in the group chat for both links, so you can just click on that if you're on your own computer. But let me share the screen here. Oops, not from the beginning, JJ, from current slide. Okay. Yeah, so you can see here both of those. If you want to, you can use the QR code. And then if not, you can just click on the link in the chat, or you can try to copy this to your device. We have had a couple people already complete the eval, so I appreciate that. Again, it's very, very important for us to have this information, both for our purposes of reporting this to the Indiana State Department of Health, and then also for improving the program. So please do these two things if you would. Again, any closing thoughts from our team at the Sim Center?
Go for it. We really appreciate your time. We know that, you know, in the current situation, ideally we would love to be face-to-face, but doing hands-on, because I think that's how we all learn best. And as instructors, we were actually talking about that. That's something that we kind of we really miss about this. But we really appreciate you taking the time. Make sure you watch the videos back if you have other questions. Share them with people if they're wondering. I've watched a lot of videos, and I think that the resuscitation videos are some of the best that I've seen. And I didn't video them, so I'm not taking credit for them. But I'm just saying, for like the video aspect of them, to get inside and be able to see that, I think those are really good. And they also can be used as resources for people to watch maybe before they do their NRP class or other things like that, just to kind of get yourself in the mode for resuscitation. But no, we really appreciate the time that you've spent. We know that everybody has busy schedules, especially now with the current things going on. We just want to thank you and make sure that if you do have any questions or things that how we can improve it, we want to improve specifically for the challenges that you guys have. So this is what it's all built around, is trying to help with the challenges that you may have in your smaller hospitals. And you know, just to bring it back totally home, I actually grew up in a critical access hospital. I worked at one from the time I was 19 till about 23, and in an ER. And I know that I've seen the most amazing work done in those ERs because of teamwork. And it's really exciting for me to be able to be a part of kind of giving back to that, but I know that there's a lot of challenges, but I do know that there's a special resiliency, sense of resiliency, I guess, with the employees in those places. So keep doing what you're doing, working with the lower resources, but working together as amazing teams. And I think that's something that critical access hospitals really do.
I certainly can't do better than that, Jimmy. So that's great. I want to add that we do have 2 more trainings coming up this week that we'd love for you to be a part of. One is on Thursday the 28th at 9 a.m. We are going to be doing training related to pediatric emergencies. And so that will be a really good one. Some of the same folks in this training will be involved in that. And then on Friday the 29th at 1 p.m. we will be doing training on adult dehydration and communication skills with Suzanne Wheeler. And so we want you to be a part of those. The great thing about this format is that it does get recorded. So this whole session, this whole training will be available to you and anybody at your facilities for as long as we have the internet, hopefully. And so we'll send that link to you and you can watch that. Please share it as much as possible. And any of the videos, any of the links that we have, any of the PowerPoints that we have, these are all yours. You can use them as you want. We'd be happy to share any of this with you. So unless there are any further questions, which I cannot see much on the chat, we thank you for your time today. Please take the test, take the evaluation. With that, we'll give you back the rest of your day, and thank you all for your time. Have a great one.
Thank you.